Can we please go live?
Yes, ma'am. Actually, I'm already working on it. Allow me a moment. Okay, perfect, perfect. So we are live right now. Let me just share my screen. Yes.
Yeah. Can I start?
Just a second. Let me. Yeah. Perfect, perfect. Good to go. We are good to go, ma'am.
Yeah. A very good evening to all our respected dignitaries, esteemed faculty members, chairpersons, moderators, panelists, and delegates who have joined us from across the country. It is my privilege and honor to introduce and welcome you to the 253rd edition of the Happy Learning Masterclass webinar series. With joining us societies today are Karur, Nagarkoil, Padukottai, Thanjavur, Theni, Trichy, Tirupur, and Vellore societies. At the outset, I would welcome our guest of honor and chief guest, and we are deeply grateful for your presence and continued guidance. A heartfelt welcome to our program director, Dr. M.C. Patel, sir, whose vision and unwavering commitment to academic excellence continue to inspire this remarkable learning platform since the time COVID started. So let us evoke the blessings of Lord Almighty before we introduce sir formally. Can we have the inauguration slide, please? The inauguration slide, please, Harsh. The lamp lighting.
Farina, stop sharing. Huh?
Ma'am, I'm already sharing the screen. The video is playing.
No, I can't hear the audio also. The screen is now visible at least.
Video is there. There is no audio.
Okay, so audio is not there.
Please double click so that we can have the audio.
Ma'am, is it visible?
It is visible, but it's not audible.
It's not.
Let the lamp be lighted. Mahakali Suryagodi Namaprava.
I believe there was some glitch for this, ma'am.
Yeah, I think. No, it's okay. Let me introduce our program director, Dr. M.C. Patel, sir. He is your presidential candidate for the year Foxy 2026. Sir has been the vice president of Foxy in the past, a chairperson of the Medical Legal and Ethics Committee. He has also held positions in the Ahmedabad Obijway Society as president of the IMA Ahmedabad, and the national president of NMO. He has also been in rural service under the Dhanvantri Seva Yatra under NMO and Seva Bharati organizations since the last 23 years. He has been serving in medical camps in Jammu and Kashmir as well as in the northeastern districts. Sir is also an author of the important Uniform Consents from Foxy, and he is an important medico-legal consultant across Pan-India and just a phone call away. Sir, we welcome you and request you to please deliver your address.
Thank you, Dr. Monica, for kind words. It gives me immense pleasure to welcome you all to this 253rd edition of Happy Learning Masterclass web series. And joining society today, Karur, Nagarkoil, Pudukkottai, Tanjore, Theni, Trichy, Tirupur, and Vellore. I welcome Dr. J.M. Kanan, madam. She has kindly consented to be chief guest. She is always with me any of my academic activity, and I am always blessed by her blessing. So welcome, J.M. madam, and thanks to sparing time to this webinar, even in spite of your very busy schedule. I also welcome Dr. Saraswati Madam. She has kindly consented to be guest of honor from Thanjavur. So, welcome. I also welcome learned chairperson Dr. Janki Ravi Kumar Madam from Pudukkottai, and she is going to chair a very interesting session of medical management of fibroid, and which will be delivered by Dr. Farina Begum from Ramnathpuram. I also welcome one more set of chairperson, Dr. Rita Vijay Selvi from Vellore and Dr. Raja Rajeshwari from Thanjore, and they both are going to chair very interesting session of surgical management of fibroid. And that part is to be dealt by Dr. Gus Dipan from Trichy. I also welcome Dr. Gayatri. She is going to chair one more interesting session. There is something. Okay.
तपासणीचा नाही केलेत बेटा.
Okay. So Dr. Gayatri will chair session which will be taken by me only, consent in OBGYN practice. I also welcome two learned moderator, Dr. Charmila and Dr. Anita Madam, and they are going to deal with very interesting panel about ovulation induction. I also welcome Dr. Vijay Prabha from Trichy. She is expert in that very panel to have her expert comments during panel discussion. And all the learned panelists, Dr. Vijay Prabha is expert, and all the panelists, Dr. Uma Brinda from Thanjore, Dr. Pushpalata Kumari from Vellore, and Dr. Surya Prakash Murthy, Dr. R. Renju, Dharmapuram, Dr. Chitra Selvamani from Manangudi, Dr. Vijitra from Karur, and Dr. Vindhya Lakshmi from Coimbatore. I also welcome my team, Dr. Monica Umardan. She is convener in this series since long. Dr. Monica Gupta, Dr. Nivedita, Dr. Satabdi, Dr. Deepika, and Dr. Megha. They all are coordinator in this series since long. And before I go to my welcome address, I thank Dr. Charmila for helping me for designing this particular webinar up to execution of this webinar. When I started this series, I invited 3 friends to start with, and Charmila was one of them. And again in this series, Charmila is there, and she is going to moderate very interesting panel. And one more coincidence, in my very first episode, Dr. Jem Kanan was chief guest, and today also Jem Kanan is again chief guest in this. I started this series with state of Tamil Nadu, and I am going to end this series with Tamil Nadu. So for this particular year, this will be continued learning process. But every year we go each and every society of Foxy one by one as far as any focus topics for discussion is concerned. And we discuss focus topic to be helpful to our obstetrician friend, our Foxian friends. And our ultimate goal is to check maternal mortality and infant mortality rate. Because by 2030, we are given a target by WHO and Government of India that maternal mortality rate should be less than 70 and infant mortality rate should be less than 12. Of course, there are few states in southern India. They are already has achieved that. 21. They have already achieved this goal, but at the same time, there are few states, particularly in northern India and northern eastern India, they had having mortality rate near 200. Of course, in recent survey, they have gone down 200, but still they are near 180 or so, and it's a matter of concern for us. Particularly obstetricians who are working in rural India, they are much more concerned to check this maternal mortality rate. And it is of course possible if you go join hand by Government of India, WHO, then NGOs like and National Medical Organization and organization like IMA, Foxy, and just I mentioned all obstetrician friends, particularly who are working in very remote India. So if we go join hand, if we pick up high risk pregnancy cases well in advance, and if we refer them at appropriate center to take care and to get delivered at all with all the facility in those center, we can check maternal mortality and infant mortality. But one more area is hemorrhage. We know as far as PPH part is concerned, still it is a major killer as far as maternal mortality is concerned. And in this particular field, if we check hemoglobin and if patient is not anemic, then we can have time to treat cases of PPH in this type of situation. So there are so many areas we have to work and we have to concentrate for the same. And of course it is possible. Of course it is difficult one. It is not at all impossible. It is of course possible. And with joint hand, one day we will achieve all this. There should not be any mortality as far as maternal part is concerned or infant part is concerned. If it is treatable, if it is preventable, it will be our duty, it will be our prime duty, I would say, to check it and to be helpful to our patient, not to end up into any kind of crisis. So with this aim, we are discussing focus topics, and ultimately our goal is to check maternal mortality. So without wasting much of your time, thanking you and welcoming you all and all the president and secretary of Joining Society and all the delegates, all the facility. Enjoy, happy learning. Thank you very much.
Thank you, sir, and we wish you all the very best for the forthcoming elections. We are very sure that you will come out with flying colors.
Thank you.
So with these wishes, I would now invite our chief guest, Dr. Jayam Kannan, madam. She has been the vice president of Foxy in 2018.
Monica, everybody in Tamil Nadu knows me well.
Yes, ma'am.
Yes.
Ma'am, please, with your blessings.
Okay.
Madam, you have to
See.
close one device, madam, because I think
Yes, ma'am, because voice is echoing, ma'am.
My voice is echoing.
close one device.
Okay. Is it okay now?
It's much better.
Much better, ma'am.
Okay. Because my internet is not all right, I had to switch on this. So, it is with greated pleasure I am meeting the team back right from 1st to 25th at 253rd this seminar, sitting at my house. Obesity is a growing problem in all areas where progress in health and happiness are also earmarked. This decade is standing out to fight against this obesity. Yesterday, when I was coming from Madhya Pradesh to Tiruchirappalli, Chennai, in the row number 2, 185 kg with 135 kg person, in between a 10-year-old child, 50 kg. They were asking for extra belt, and it was looking very bad. Mother, father, and child, everybody being so obese. It was really a sight which I could not see, and about which there is going to be a good topic here, and I am very happy about it. Coming to Dr. M.C. Patel, my younger brother, has been traveling with me in Foxy since 2001. I have gone with him to many places in Ahmedabad. 10 years earlier, we used to travel 6 hours, 8 hours by bus, starting by 3 a.m., reaching the place like Jamnagar, other places by 10 o'clock only. And he used to be with me in all those places. And we have been together as vice presidents in 2018, and we have worked amazingly together along with Pratima Patel and Dr. Rajat Ray and others under Jaideep Malhotra. As we are all having experts in endoscopy, experts in infertility, ultrasonography, telemedicine, MC Patel is an expert in ethical medicine. He is the king of ethical medicine, and he can give message at any time to anybody. He is an academician as an highest qualified ethical medicine person, and he is also an highest in his administrative capacity, and also the humblest person who is available 24 into 7 into 365 days for anybody for any questions on ethical problems. I have referred many people to him for ethical problems. So, as endoscopist, we all know people well. Now, we are going to know Dr. M.C. Patel as the master of ethical medicine, and he is going to occupy the highest chair of Foxy with all his endeavors and hard work, because for the past 4 years, he has done the 253 program. I bless you, MC,
Thank you,
from
madam.
the heart and soul of myself, and wish you a great journey ahead from August 2nd week onwards. All the best for you.
Thank you, madam. Thank you for
Thank
sparing time for us for this webinar, and you are always with me. Whenever I have called, you simply said, yes, I am there. So
Yes.
thank you, madam.
How can I be said no to my brother, you know?
Thank you,
I
madam.
can
Thank you.
fight with my brother. I can beat
Yes.
my brother.
Yes.
But I
yes,
have to be always going
yes,
with my brother.
Yes.
I cannot say. Anybody can say anything, but
Yes,
I am
yes.
with my brother.
Thank you,
Thank
madam.
you, brother.
Thank you.
Thank you. Bless you all. Bless you all.
Thank-
Bless all the persons in this
Thank
great CME who have come here.
Yes.
Thank you.
Thank you, ma'am, for encouraging words, and we wish all what you have said comes true by the end of August. Thank you so much. Can I now request Dr. Monica Gupta, madam, to please introduce our guest of honor, Dr. Saraswati, ma'am.
Thank you, MC Patel sir and Monica, for giving me opportunity. Dr. Saraswati ma'am, she is a consultant in Thanjavur, and she has served as a professor OBGY in the medical college over there for 13 years. She was twice secretary of Thanjavur Society and presented so many paper, poster in the national as well as international conferences. And she is deeply interested in ultrasound, in gynecology, fertility, minimal invasive surgeries, and she is doing a lot of work on lactational services for breastfeeding mothers. Over to you, madam, for your blessings. Madam was there. Madam Saraswati, ma'am, please say a few words of blessings to us.
Madam is there but muted hai.
Madam, please unmute yourself. Madam was there from the start only.
Yeah,
I think she was the first person to join.
we can see her there, but
No,
abhi
she is there, but she is muted.
muted. And
Saraswati, madam, please unmute yourself.
Saraswati, madam.
Should we give a call to her? Or?
Yes.
Madam, I'm just calling her.
Okay.
Okay.
Meanwhile, we all are touched by the love and
Yes.
affection what JM madam has shown to MC Patel sir.
Yes, Dr. Monica, we are just so enthusiastic. It's such a, I'm overwhelmed with what Dr. Jayam ma'am has said. And
But-
also, historically, जो sir ने बताया कि Dr. Charmila and Dr. Jayam were the first at his inaugural Happy Learning Masterclass. Like they started the ball rolling. And it's just, it's so...
Ma'am, please, ma'am is there. Ma'am, please give your words of wisdom.
Yes.
Saraswati ma'am.
Yes, ma'am.
Hello.
yes, welcome, madam.
Welcome, ma'am.
Thank you, sir. Thank you so much. I'm really honored and privileged to join this 253rd and still going strong masterclass series by Dr. M.C. Patel. I'm to see a person of such stature asking me to join as a guest of honor. And like the rest of us, I'm waiting to learn. I'm waiting to learn much from the mixed bag that is going to be live stream today. And thank you so much, sir.
Thank you. Thank you, madam.
Thank you, ma'am, for your words of wisdom. Over to Monica to officially announce the closure of the inauguration and start with the academic program with sir's permission.
Yes, go ahead.
Thank you, Jaya ma'am and Saraswati ma'am, for joining us for the inauguration today and your blessings. Sir, with your permission, we will start with the academic session, and I would now invite Dr. Deepika Logane to please conduct the first session.
So thank you so much. Thank you, Dr. MC Patel sir, Dr. Monica Umardand, and Dr. Monica Gupta for this opportunity. And thank you, Dr. Jayam ma'am and Dr. Charmila ma'am. We are हमारी campaign में और sir के साथ में हमारा जान आ गई. You know, you have really made us so enthusiastic, and we have received your blessings. We are really thankful, grateful to you. So now with that, we welcome you to the first scientific session. And the topic for this session is medical management of fibroid. And it is now my proud privilege to introduce the esteemed chairperson for this session. Our chairperson is Dr. Janki Ravi Kumar ma'am. Can we have a CV, please? Yes. Yeah. So ma'am is the president of the Pudukkottai OBGYN Society of Foxy, a respected clinician and academician. Ma'am has been actively contributing to women's healthcare and to the academic activities of her Foxy Society and Foxy at large. Ma'am is widely appreciated for her dedication to patient care and her commitment to advancing obstetrics and gynae practice. Ma'am, a very warm welcome to you. Ma'am, is ma'am there? Can you tell me? Or can I go ahead and invite the chairperson?
Yeah. Invite
Can I?
other chairperson. Yeah.
Yeah, I'll go ahead and invite our speaker for the session, and who is none other than Dr. Farina Begum, ma'am. Ma'am is a consultant obstetrician and gynecologist and reproductive medicine specialist at Syed Amal Trust Hospital at Ramanathapuram at Tamil Nadu. Ma'am holds the qualification of MBBS, MRCOG, along with a fellowship in reproductive medicine. Ma'am is actively involved in postgraduate teaching, clinical training, safe motherhood initiatives, research, and continuing professional development programs, and is committed to promoting guideline-based, evidence-based women's healthcare. Ma'am's special clinical interests include high-risk obstetrics, IVF, reproductive endocrinology, and evidence-based obstetrics and gynecology. With her expertise in reproductive medicine and evidence-based clinical practice, ma'am is indeed the ideal person today to speak on this topic of medical management of fibroid. And ma'am, we request you to go ahead and start with your talk. The floor is all yours, ma'am. Welcome, ma'am.
Stop sharing.
Oh. The technical team, Harsh, please stop sharing. Allow ma'am to share, please.
Yeah. Farina, share your slides.
Yes.
Good evening, everyone.
Make it slideshow, Farina.
Ma'am, there's a button on the extreme right-hand corner to start the slideshow.
Farina, கீழ இருக்கும் பாருங்க. 4 இது அதுல வந்து yeah, from the beginning. Yeah, right. Yeah, perfect.
Thank you, ma'am. I begin my talk with heartfelt thanks to dear Dr. Charmila ma'am and MC Patel sir for giving me this opportunity. I also thank Dr. Deepika ma'am for her kind words of introduction. Thank you so much, ma'am. Without any delay, I'll proceed with my talk. My topic is medical management of fibroids. As we all know, fibroids are a common undertreated problem. Around 70 to 80% of women develop fibroids by the age of 50 years, but only 30% of them become symptomatic. And it is still the #1 indication for hysterectomy in India. And we all know that fibroids are steroid hormone dependent, and they are basically clonal origin. They are raised from single myometrial cell. But the further drive for the growth of the fibroid is from estrogen and progesterone, who upregulate the growth factors and extracellular matrix. Now, whether it is estrogen or progesterone, we all think estrogen is the main culprit actually, but it is the progesterone who is the major culprit. Fibroids, though they have abundant estrogen receptors and progesterone receptors, it is estrogen which promotes the expression of the progesterone receptors in the fibroid. The progesterone then stimulates the cell proliferation, extracellular matrix deposition, and inhibits apoptosis, which will contribute to the growth in bulk of the fibroid. So progesterone is the major driver, whereas estrogen is the fuel for the drive. Now, this is a famous slide which we all might already know, which is the FIGO-Leo-myoma subclassification system. I purposely put it just for us to revise because my topic is medical management of fibroids. I just want to emphasize here that FIGO 0, 1, 2, and 3 fibroid are better managed surgically than medically because they are more notorious to cause fertility issues. They're more notorious to cause heavy menstrual bleeding and dysmenorrhea. So it's important that before we decide on the management of fibroid, we map the fibroids. So next, the FIGO correction in 2000. Coming to the FIGO 2018 correction, type 3 fibroid is now submucosal. Can everyone hear me clearly now? I find my voice echoing.
Saraswati ma'am's phone is echoing, ma'am.
Okay. Coming to the symptomatology of fibroids, so we already saw that 50 to 60% is asymptomatic. So the remaining 25 to 30%, which is symptomatic, the most common symptom will be heavy menstrual bleeding, which is usually associated with dysmenorrhea, and it's a spasmodic, sometimes even congestive dysmenorrhea, and there is heavy with or without prolonged menses, and there is a typical bleeding pattern. If there is coexistent intermenstrual or postmenopausal bleeding, we have to exclude coexisting endometrial pathology as well. Coming to the bulk related symptoms, if the fibroid is huge, it can produce pain and pressure symptoms. Anterior wall fibroids will cause frequency of urination. Posterior wall fibroids will cause retention of urine, and huge fibroids can also cause hydronephrosis. And fibroids, especially if FIGO 0 to 3 fibroids are implicated in the infertility and recurrent pregnancy losses as well. And they can also produce complications during pregnancies like preterm labor. Coming to indications for medical management, moving into the topic as such, who needs medical management? So the important first criteria is size. A fibroid, very huge fibroids will not go for medical management. So small fibroids which are symptomatic. Again, asymptomatic fibroids will not go for medical management, usually go for expectant management. And second point is symptomatic intramural and subserosal fibroid. I already mentioned that FIGO 0 to 3, which are submucous fibroids, they are better amenable to surgical correction rather medical management. So these are two important points which I want to emphasize in the medical management. Coming to other indications, pre-operatively, when we want to buy time for the surgery, like when we want to improve the medical condition of the patient, when we want to improve the hemoglobin of the patient, or patient wants to buy time, she wants to postpone her surgery due to medical or personal reasons. And in the perimenopausal time, when we think she might land up in menopause in a few months or a few years, we can go for medical management so that thereafter, after menopause, her fibroids may shrink automatically. So they're also indicated when you want to delay the surgery, when the patient is unfit for surgery and in fertility preserving movement, we can go for NSAIDs and tranexamic acid if they present with heavy menstrual bleeding and dysmenorrhea. Along with that, we can continue the fertility treatment. So the management of fibroid depends on the size, symptoms, location, whether she wants fertility and whether she wants her uterus or not. Now, the the drugs which I am going to discuss in the subsequent slides, I've divided them into 2 groups of drugs. First group will be the group of drugs which will cause alleviation of symptoms only. That is, they will cause a reduction in heavy menstrual bleeding and dysmenorrhea. And the second group of drugs are drugs which will help reduction of the symptoms as well as reduce the volume of the fibroid. So symptomatic management will be tranexamic acid, NSAIDs, combined oral pills, oral progestins, and Mirena. Along with symptom reduction, if you want volume reduction, we'll go for GnRH agonist or antagonist, selective progesterone receptor modulators like ulipristal or mifepristone, and aromatase inhibitors. We'll discuss the drugs one by one. First drug which I'm sharing is NSAIDs. NSAIDs, every one of us know pain is because of prostaglandins. So we want to attack the prostaglandins, and that's how NSAIDs help us. They are COX-1 and COX-2 inhibitors, which will reduce the prostaglandin in the endometrium and the fibroid tissue, and hence help in pain relief. We can use our drug of NSAID of choice, which you are used to giving in the OPD practice. We can give mefenamic acid, ibuprofen, naproxen, or diclofenac according to the patient and doctor's preferences. Coming to tranexamic acid, the fibroids which cause heavy menstrual bleeding. If you see, the endometrium overlying the fibroid is richly vascular, and it has high fibrinolytic activity because of increased tissue plasminogen activator. So we need a drug which will attack this fibrinolysis, which is tranexamic acid, and the dose will be 500 milligram to 1 gram TID. So these are very short-acting drugs we can give in the acute phase of heavy menstrual bleeding. Now coming to the hormones, combined oral contraceptives, oral progestins, epot-medroxyprogesterone, and levonorgestrel acetate. So we just studied that estrogen and progesterone are the drivers for the growth of the fibroids. But again, how COCs will help, how progesterones will help in the management, we might wonder. But we have to understand that these drugs are targeting the endometrium, not the fibroid. They are causing profound endometrial atrophy. They reduce dysmenorrhea and heavy menstrual bleeding by acting on the endometrium rather than the fibroid. Also, it's important to understand that there is no volume reduction of the fibroids with these drugs, except there are in DMPA, there is a study which is quoted 2 to 3 doses of DMPA. Over at 3-month interval has helped in the reduction of volume of the fibroids with symptom relief. So with this group of drugs, the COCs, the progestins, DMP and LNG, we are treating the symptoms and not the fibroid. Now going to the second group of drugs, which will help us in reduction of the volume of the fibroids as well. First, selective progesterone receptor modulators. The mifepristone or ulipristal acetate are the drugs which have been extensively studied in this group. Unfortunately, both of them are not approved by FDA for the management of fibroids, but there are significant number of studies have been quoted that they are very useful in the management of both symptoms as well as reduction of fibroid volumes. So now coming to the mechanism of action of these drugs. So they are basically progesterone antagonist at fibroids. Fibroids have progesterone receptors. So these drugs will go and inhibit the progesterone receptors, and hence they will reduce the size of the fibroids through inhibition of the cell proliferation and inducing apoptosis. The second will be the action of this drug on endometrium. So there could be mild endometrial atrophy, but there is a little agonistic action on the endometrium of these drugs, which can cause proliferative changes, which is called as progesterone receptor modulator associated endometrial changes, which we will be discussing in the coming slides. Also, these drugs can cause amenorrhea by inhibiting ovulation, though this action is not so profound. Now, coming into ulipristal acetate, the dose which has been studied is both 5 milligram and 10 milligram. Both of them has been found to be equally effective. It induces apoptosis in the fibroid and inhibits cell proliferation. There is significant reduction in the symptoms. Along with that, there is reduction of the fibroid volume as well. There is a European trial which came in 2012, which is a Pearl trial. This is a 4-phase. It was conducted in 4 phases. Pearl 1, 2, 3, and 4. In Pearl 1, the drug, the ulipristal acetate, both 5 and 10 milligram was compared to placebo, in which they found out that there is 90% reduction in the bleeding, 70 to 80% reduction in amenorrhea, and around 10 to 20% reduction in fibroid volume. Pearl 2 study, which compared the ulipristal acetate to leuprolide, and it was found that ulipristal acetate is non-inferior, faster onset, and better action compared to leuprolide. Pearl 3, it was compared to norethistone acetate, and it was proven to be as effective. And Pearl 4, it was a long-term trial in which they studied up to 4 courses, which means around a year. 1 year it was studied. One course is 3 months. So 4 cycles were studied, and there was significant achievement of amenorrhea, as well as there is reduction in fibroid volume, and there is no increase in significant adverse effects. This studies was going on, and then came the report of liver injury. Around 5 cases of liver injury was reported with UPA, and of which 4 required liver transplant, after which MHRA issued the safety alert. They advised not to initiate new treatment courses of ulipristal even in patients who have completed treatment courses previously, and they formulated strict protocols that we should do LFT every month in patients taking UPA. And if transaminase is more than 2 times the upper limit of normal, we have to stop the drug. And even after you stop the drug, we have to do LFT 2 to 4 weeks later. Now, this is the ulipristal treatment protocol. First, we have to confirm that whether patient is eligible for medical management or not. Then you should do a baseline workup for the patient, which should include an LFT. Then you can start the drug UPA 5 milligram orally once daily. It's preferably started within the first week of the cycle, continuously for up to 3 months. But you have to call the patient every month and do an LFT. At the end of 3rd month, you assess the symptom, whether she's got bleeding control, pain relief, and reduction in the size of the fibroid with the vaginal ultrasound. And then we have to allow a treatment-free interval, after which you have to do an LFT 2 to 4 weeks after stopping, and then you can repeat the course as and when needed, total of 4 courses. So as I already told, whenever there is a derangement in LFT, kindly withhold the drug. Coming to mifepristone, it's also a progesterone receptor antagonist. Again, mifepristone, various doses have been studied in every, multiple trials have been conducted with different doses of the drugs from 2.5 to 50 milligram. There is, according to Cochrane 2012, there is significant reduction in the menstrual blood loss and symptoms, but there is not that much significant reduction in the volume of the fibroid, and there is a concern about the endometrial changes with mifepristone. It's an Indian study which has compared the dose of 10 milligram versus 25 milligram of mifepristone. Both are found to be equally effective, but 25 milligram has a significantly higher rates of nausea, vomiting, and gastrointestinal disturbances. So we can start with a lower dose and then move on to a higher dose. This is a Cochrane review on both all the selective progesterone receptor modulators. These studies have come. They have compiled studies of mifepristone, ulipristal, and isoproterenol, and the primary outcome was fibroid-related bleeding, pain, symptom severity, and quality of life. It was found that there is an improvement, 20% improvement in symptom severity, and 22% improvement in quality of life, 80% reduction in menstrual blood loss, and a very varied number of 23 to 96% amenorrhea. But there's no conclusions regarding the pelvic pain. Now coming to the progesterone receptor modulated associated endometrial changes. So we already saw there is an antagonistic action in the fibroid, and there is a slight agonistic action in the endometrium, which causes proliferative changes. And we have to understand these changes are non-cancerous and they're mistaken for endometrial hyperplasia, but true endometrial hyperplasia and atypia are not observed in patients who took ulipristal and mifepristone. But one concerning feature with mifepristone and ulipristal is that though they produce a significant reduction in the bleeding, they did not cause that much reduction in the fibroid volume. The interaction, why as to it did not produce significant reduction in uterine volume is still not understood well. Now coming to the next group of drugs, which is JNRH agonist, you can go for a leuprolide acetate Depot or buserelin or a goserelin. How it acts, it will act on the hypothalamus. So once it goes and sits in the hypothalamus, there will be an initial flare effect for 7 to 9 days, but they are long acting. So the receptors are occupied for a longer period. So after 7 to 9 days, there is suppression, which will cause reduction in LH and FSH, as a result of which there is reduction in the ovarian estrogen and progesterone production, and hence the fibroid will reduce in size, and hence there will be reduction in bleeding, pain, and improvement in hemoglobin. But we have to understand that these are for not more than 6 months, we should not use this drug. There is a 36% reduction in the size in 3 months. After stopping the treatment, the size will come back to the original size in 4 to 6 months of time, and menses will resume in 4 to 8 weeks. But these are the ideal drugs for preoperative period. There will be significant reduction in the size. Because of the significant reduction in the size, we can convert a vertical laparotomy incision into a fan and steel, or we can convert an abdominal to a non-descent because of the reduction in size. There is an improvement in hemoglobin, there's a reduction in blood transfusion during surgery. So it's an ideal drug to be used in the preoperative period. Coming to GnRH antagonists, which are the latest molecules, that is the elagolix and relugolix. Again, the elagolix studies in fibroids has used a small dosing of 300 BD, whereas in endometriosis, they've used 150 and 200 BD. So we'll first see about elagolix and then move on to relugolix. So the Ilaris trial is for elagolix. So there are two arms, Ilaris UF1 and UF2. Around 400 women were involved in the study. Premenopausal women aged 18 to 51 years with ultrasound confirmed fibroids and heavy menstrual bleeding were included in the study. And 3 arms. The first arm took elagolix 300 milligram BD with add-back therapy. And second arm only elagolix for 300 milligram BD. And third arm is placebo. And it was found there is a significant reduction in the heavy menstrual bleeding, both with add-back and when the molecule was used alone. So this is the elagolix protocol which we should apply. Again, first, any patient, we have to confirm whether she is fit for medical management or not. Do a baseline transvaginal scan, map the fibroids, and since this is a drug which can cause hypoestrogenism, we can do a baseline BMD, especially if risk factors for osteoporosis are present, and a basic blood pressure and lipid profile can be done. And the drug is given as 300 BD. Periodic review is important, and maximum usage should be 24 months. Beyond 24 months, there could be continued bone loss. Beyond this duration, the bone loss could become irreversible, so not more than 2 years. Coming to relugolix. Relugolix, the trial is Liberty trials. Again, here also the same inclusion criteria. Premenopausal woman, ultrasound confirmed diagnosis. And we have to see the inclusion criteria clearly, because the submucosal, entirely intracavitary submucosal fibroid, that is the figure 0 and 1, we should not subject them to these drugs. They are better managed surgically. So again, there are 3 arms. One is the relugolix 40 milligram, estradiol 1 milligram, and norethindrone 0.5 milligram. So the idea of adding add-back is estradiol is to overcome the hypoestrogenism because of the relugolix. And the idea of adding norethindrone is to overcome the undue estrogenic effect of estradiol. The second arm is the placebo. Third arm is delayed relugolix combination therapy. Again, in delayed arm, initial 12 weeks, they've given only monotherapy. Then they have shifted to 12 weeks of with add-back therapy. The primary endpoints were studied with menstrual blood loss and 50% reduction in the blood loss, total volume, and 50% reduction in symptoms. Secondary endpoints, again the same. Along with that, distress, anemia, pain, fibroid volumes, and uterine volume. And both the arms, the relugolix combination therapy and delayed combination therapy, there was significant reduction in the menstrual blood loss and 50% reduction in blood volume from the baseline. And so this trial was extended to another few more weeks. So this slide shows there was amenorrhea. It started even within 4 weeks of use, and there was peak amenorrhea at 8 weeks, and it continued till 24 weeks. So the Liberty trial was extended to another 24 weeks, which is 52 weeks, around at 1 year. and there was a profound reduction in amenorrhea, reduction in pain, reduction in the volume of fibroids as well. Still, again, the study was extended to another 52 weeks, which is another 1 year. Around 104 weeks was studied, and significant improvement in the menstrual blood volume and uterine fibroid volume was achieved with this wonderful molecule. And again, Relugolix protocol, as we already told, we have to see whether she is fit for the medical management. And here we are giving estrogen and progesterone as well. So any thrombotic risk patient we should not include in this category. Patients who have thrombotic and bleeding risk, baseline workup which we should do, and then start during the menstrual bleeding after doing a baseline examination. It's a 1 tablet orally once daily, and preferably taken in the same time each day. And during the therapy, we have to periodically review the patient, and hard limit is maximum 24 months of use. Beyond 24 months, it's better to discontinue therapy. So my last slide is about letrozole, last drug which I have included is letrozole for fibroids. So we saw that there is an aromatase overactivity, overexpression in the fibroid. So letrozole is an aromatase inhibitor. So there can be it could inhibit the peripheral conversion of androgens to estrogen. So dosing is 2.5 milligram OD for 3 months, and then you can give a progesterone withdrawal for her to bleed. But it is still under trial, and the trials are too small and too heterogeneous, and there are no long-term RCT evidence. So the limitations of medical management, so it's a short-term therapy, though we have 2-year therapies with Relugolix and Elagolix now available. And before starting the medical management, we have to counsel the patient that fibroids will not vanish forever. It is mainly we are targeting the symptoms. There could be reduction in the fibroid volume, and there could be recurrence after stopping the treatment. So counseling beforehand is important before starting medical management. This is slide which summarizes my entire presentation, not going into the details. Take home message: choosing the right patient is important, because we cannot choose a patient who is a candidate for surgery for the medical management. That is the first thing. And whether she is fit for the drug, whether she is she's not having any medical contraindications for the drug. We have to choose the right drug second, and do not overpromise results and offer surgery when clearly indicated. Thank you.
Thank you, ma'am, for
Patel,
the
sir.
elaborate presentation. Yeah. Requesting the chairpersons to please give the inputs for this wonderful talk on medical management of fibroids.
Patel, sir, for your comments, sir, because Madam couldn't join as chairperson. Hello.
Yes.
Yeah.
Sir, could you give the concluding remarks?
Oh, yes. So it was very crisp and to the point presentation, and how to deal with fibroid if medical management is possible and not to end up into surgical. And very rightly mentioned, no overpromise, because we cannot give guarantee of result in any situation, because we know in fibroid recurrence is also known. And if we have promised that with medical management everything will be good and there will not be any recurrence, and if at all recurrence happens, then it will be troublesome to face patient. And in this type of situation, patient may prefer to go for shoe also. So nicely mentioned by that point also. So congratulations, Farina madam, and thank you for accepting our invitation to deliver this important talk.
Thank you, sir.
Yes.
Thank you, sir. And with due respects to the chairpersons of the last session, as well as the wonderful speaker and Dr. MC Patel, sir, we move on to the second session. And this session is on surgical management of thyroid. To chair this session, we have with us the President, Vellore Obs and Gynae Society, Dr. Preeta Vijaya Selvi. Ma'am is the professor and head, Christian Medical College, Vellore, with PG alumni of CMC Vellore, 17 years of teaching experience of both undergraduates as well as postgraduates, a faculty in medical education, Regional Nodal Center CMC Vellore. She is got 26 publications in various journals, and her area of interest is in quality in care and obviously medical education, medical care in primary and secondary hospital. She's a member of WOXI, POXI, as well as SOMI. The next chairperson for the same series is Dr. R. Raja Rajeshwari. Ma'am, she is the professor and head of the department of Thanjavur Medical College. And she's got multiple awards, of which the most important, I feel, is the Best Doctor Award in 2018, as well as in 2019. She is a postgraduate and undergraduate teacher, a member of the undergraduate curriculum committee, 30 years of experience teaching in high-risk interest, 30 years of experience interested in high-risk pregnancy, presented multiple papers in national as well as international journals. I request any of the chairpersons present, if they can please introduce the speaker for today.
Good morning, good evening, everyone. In the first instance, I would like to thank our Dr. Patel sir. Sir had actually come to Tanjavur, and he had given an excellent session. And thank you, my heartfelt congratulations, sir. I look forward to see you as the president of FOXI in the coming election. We will definitely vote for you, sir. And then, shall I introduce, or can Madam introduce the speaker? Madam?
Madam,
anybody of you can.
Shall I introduce, Madam?
Yes, madam, you can introduce.
Okay. Yeah, the speaker is Dr. Gajadeepan sir. He is a rare combination of a specialist in both infertility and laparoscopy, alumni of JIPMER and AIMS, a diploma in reproductive medicine from Germany. He has got a fellowship in clinical sexual medicine. He has got many feathers to his cap, received the Best Paper Award in the International Congress, and recipient of the Young Talent Grant Award from Melbourne, Australia, and recipient of the Rising Star Award. He is currently Secretary, South Tamil Nadu IFS chapter, and an apt person, eminent lap surgeon, to talk about the surgical management in endometriosis. Over to you, sir. We welcome you, and over to you, sir. Thank you, sir.
Can I share the slide? Thank you, ma'am, for the kind introduction. And I'd like to thank James Kanan, ma'am, Patel sir, and Charmila madam for giving me an opportunity to talk on the surgical management of fibroid uterus. And is my slide shared?
Yeah, it's visible, Gajadeepan. Gajadeepan, you have to rename yourself. It's coming as admin.
Okay.
Otherwise, the host can, the technical person can rename Dr. Gajadeepan, please. Monica? Monica, can you ask them to, otherwise you start, Gajadeepan, like
okay, ma'am, okay. So my previous speaker was talking on the medical management.
Make it into a slideshow. It has gone off into the other mode.
Yes, slideshow. Yeah,
Gajadeepan sir, sorry to interrupt. I have just renamed you. Okay, perfect.
Yeah, it's correct. Yeah, thank you so much.
Yep.
Yes, ma'am. I'll start my presentation. Good evening, everybody. My talk of today will be on the surgical management of fibroid uterus. Already the previous speaker was talking about the medical management of fibroid uterus. So my talk will be, the outline of my talk will be on, is my slide visible? Hello?
Yeah, it's visible. It's visible.
Yes. So my talk today will be on the preoperative evaluation of the blood loss during a surgery, and which mode we are going to do it, whether we are going to do it by laparoscopy or hysteroscopy. And after fibroids, when we advise the patient to become pregnant, or if you're going to do an IVF, when we are going to tell the patients to go for an embryo transfer, and the complications which we can face in pregnancy, and how and when we are going to do the plan the termination of pregnancy, whether it is going to be allow the patient for the vaginal delivery or we do an elective cesarean section, and the complication which we are going to face during the surgery or cesarean section after a previous myomectomy. So how we are going to diagnose a fibroid is by the clinical evaluation, clinical examination, by which we can diagnose fibroid. Ultrasonography is one of the features by which we can find. 3D ultrasonogram is more sensitive than a normal ultrasonogram, which helps in fibroid mapping. Hysteroscopy, we do it to differentiate between intracavitary myomas and sometimes when we have a doubt about the endometrial polyps. MRI can be done when we find the fibroid size is large, or if we find the number of fibroids are more, or when we find it is in the location is very proximity to the endometrial cavity, then we can think about doing an MRI. Submucosal fibroids are best diagnosed by MRI because it has a 100%. Other modes are like SIS and hysteroscopy, which I discussed. So coming to the classification, with the same classification was discussed by the previous speaker. This classification can help us in planning our surgery, like which mode we can do the surgery, whether we can approach the patient by a laparoscopy or which we can approach the patient by hysteroscopy in doing a myomectomy. So with this classification where the type 0, 1, and 2, we can do a myomectomy by hysteroscope. Whereas type 3, 4, 5, 6, 7, 8, we can approach the surgery by doing a laparoscopic mode of surgery. This is another classification by ESGA classification for submucosal myomas, where the type 0 you find entirely within the endometrial cavity and no myometrial extension. It's a pentoclinic fibroid. Type 1 is less than 50% myometrial invasion and less than 90-degree angle of myoma surface to the uterine wall. The type 3 is more than 50% myometrial extension and a more than 90-degree angle of myoma. We have another classification which is called the step W classification, which has around 4 points, which is the penetration of the myoma, the largest myoma of diameter size, extension of the myoma base into the endometrial cavity, and the location of the fibroid, the topography, how much it is attached to the uterine wall, where it is attached. So we have like 0, 1, and 2 we have divided, and there's a score for this. And if you add the total score, and it is going to be less than 4, the points is going to be less than 4, then we do a hysteroscopic myomectomy in a single setting. So what this classification says is that whether we can finish the hysteroscopic myomectomy in a single setting, or we may need 2 settings to do the surgery, or how complex is the surgery of the hysteroscopy is going to be. So usually if you find a score of less than 4, it is high probability that you're going to do this surgery completely without any residual myomas and in a single setting. Whereas if you find a score of 4 to 7, it says that you may require a 2-setting hysteroscopic myomectomy. And if it is more than 7, it needs a complexity of the surgery is there, and we may have to intervene with other modes also. So when we are going to do a surgery for a fibroid patient, when you have a heavy menstrual bleeding, the patient is not getting subset with any medical management. When you have a bulk-related symptoms like the pelvic pain and pressure, and the anterior wall frequency, anterior wall because of urinary retention or frequency, or a posterior wall retention, when it's a large fibroid, when you find hydronephrosis, or when you find a patient who's approaching with you for infertility, or when find a patient with recurrent pregnancy loss, like for example in submucosal fibroids, then you can think about doing a surgery for a fibroid uterus. Surgery can also be done in certain conditions like emergency conditions like fibroid denervation, torsion, or you can find the patient with bleeding and the fibroid is prolapsing out of the vagina. So these are the emergency conditions where we have to do a surgery when you find a patient present with the acute pain in torsion of the fibroid, or when you find some risk factors are there with the large subserosal fibroid and a long thin stalk, and you find there's high risk for torsion. When you find a patient presenting with a prolapse of fibroid which is coming out of the vagina, a pentoclinic type 0 or 1, or when you find some fibroids having suspected to have gone for degeneration, when you find a patient presenting with pelvic pain or fever, and you diagnose these things by MRI, then you have to definitely do a surgical management for fibroid uterus. And another important reason where we do a myomectomy or a surgery for a patient with fibroid uterus is a patient with fibroid and infertility. Why the infertility causes, the fibroid causes infertility is because of the alternation of the local anatomy. A functional change because of the increased uterine contractility or the impairment of the endometrium mitochondria, or there is a change in the local hormone which leads to impaired gamete transfer or reduced blastocyst implantation. So what does the article of fibroids and infertility says? A systemic review said that fertility outcomes are decreased in women with submucosal fibroids, and removal seems to be very beneficial. Subserosal fibroids do not affect fertility outcomes, and removal is not benefited for subserosal fibroids. For intramural fibroids, it depends upon the number of fibroids, how close it is to the endometrium, and the size of the fibroids. You can decide whether to do a surgery or not. So the review says that definitely for a submucosal fibroid, you should do a surgery to enhance the fertility. So as I said earlier, subserosal fibroids, there's no effect on fertility. For a submucosal fibroid, there is an effect because of the low pregnancy rates, low implanted ratio, and myomectomy improves the outcome. Intramural fibroids, it depends upon the size, number, proximity, and the location. So my conclusion is that in an asymptomatic patient with cavity distorting the myomas, myomectomy we consider to improve the pregnancy rate. Pregnancy is generally not advised to improve the pregnancy outcome in asymptomatic infertile patient with a non-cavity distorting myomas. Myomectomy can be done in myomas causing severe distortion, and it is going to have a difficulty in assessing the ovaries during ovum pickup or in procedure. So fibroids, and coming to fibroids and miscarriages, there is no increased instance of spontaneous abortion with uterine fibroids. And submucosal large intramural fibroids may decrease the fertility and also may affect the implantation. So there's an insufficient evidence that hysteroscopic myomectomy is required to reduce the early pregnancy loss. So coming now to the topic of sarcomas. Sarcomas you find around 0.05 to 0.28%. It is because you find in patients with advanced age, long-term use of tamoxifen. Clinically, how it is because of the rapidly growing mass, features suspected metastasis, you can suspect sarcomas. Sarcomas usually diagnosed by increase in LDH level of 3 levels. Imaging by ultrasound features, if you find a mixed echogenic and a poor echogenic parts, central necrosis, color Doppler findings of irregular vessel disruption, you can suspect sarcomas. MRI is the best investigation to diagnose sarcomas, but it does not be very 100%, but somehow it helps with the condolean contrast. So a preoperative evaluation by the actor obstetric and gynecology, what they have said is that however you do an MRI, only approximately 50% of the leiosarcomas are identified before surgery. So what we can do is that intraoperative is the best method to think about whether it is a sarcoma or it is a non-sarcoma. Frozen section is not reliable because it gives a high false result in frozen section. Hysterectomy should not be done since you think it is a sarcoma or a neoplasm. A second surgery should be planned based on the histopathology diagnosis when you get the diagnosis confirmed. So as I said, now the management of surgical management, which as I said earlier, is if there is a failed medical management by heavy menstrual bleeding or when it's a bulk-related symptoms or patient desires to have pregnancy. So how we are going to preoperatively evaluate a patient before doing a surgery is that as a general or all patients, we do a CBC, LFT, RFTs, we do everything, ultrasonogram, we do to map the fibroids, we do an endometrial sampling to rule out any endometrial pathology. If you find a patient is approaching you with infertility, you should do a complete workup to rule out other causes. How is the tubes, how is the ovaries? So other causes should be evaluated. And the preoperative measures is just to see whether hemoglobin is not less than 10, whether we can give any other thing as a preoperative medications to reduce the blood loss and the uterine size, and we can plan the surgery accordingly, usually done in the follicular phase. So sometimes a pre-treatment with a gonadotropic releasing hormone analog or ulipurostol acetate can reduce the size of the fibroid, and the hysterectomy or myomectomy can be done. What are the basic principles which we have to follow when we do a surgery for myomectomy? Our thing is there's an optimum. We have to reduce the time of the surgery, limit the blood loss, limit the number of incisions. So usually there are a lot of techniques which are involved in limiting in doing the surgery, like the tunneling technique or the bony wood incision when you find a fibroid in the posterior frontal fibroid. And when you are going to do it, make sure to identify and dissect along the pseudocapsule. And the repair is always decided after removing the fibroid, depending upon the depth of fibroid which you have removed. If you have to find a depth, then a multi-layered approach is required. And after doing the surgery, you make sure that you can put some adhesive barriers to prevent adhesions. There are a lot of techniques are there to reduce the blood loss. Usually we do a laparoscopic myomectomy. And there are a lot of techniques which are there, like by using a hypotensive anesthesia when starting with the surgery, by using some clamps like Bonies and myomectomy clamps. Then you can use a tourniquet. Like tourniquet can be applied You can palpate the uterine artery, make a 1 centimeter incision in the clay space, lateral to the uterine artery, pass the tourniquet, and you can tie it anteriorly, and this reduces the blood loss. Make sure that you remove the tourniquet within 20 minutes to 30 minutes and don't leave it like that. The commonly used pharmacological drug is a vasopressin, which acts by constricting smooth muscles of the blood vessels, reduces the blood loss. A dose is around 20 units and 100 ml of normal saline. The duration is, it acts for around 1 hour to 2 hours. Make sure there's no adverse effects like brady or cardiovascular collapse. So the vasopressin is one of the good drug, and there was a study done in AIMS where they compared the comparison of intramyometrial vasopressin plus rectal mucosa reduces the blood loss compared to only using the vasopressin. So additional use of rectal misoprostol with the vasopressin, there is a significant reduction in the blood loss. So what I want to conclude is that preoperatively by using a vasoprostol or a vasopressin or a misoprostol, we can reduce the blood loss. Other methods or other pharmacological drugs also is there, like the bupivacaine, tranexamic acid, which also has some low quality evidence in reducing the blood loss. So for prevention of additions, which I said you after doing the surgery, you can use a lot of barriers like Intraseed, grafts, ceprafilin, and liquid barriers like polyethylene glycol can be used. So coming to how we are going to approach the surgery, whether we are going to do a hysteroscopic myomectomy or whether we are going to do a laparoscopic myomectomy. So when you come to the hysteroscopic myomectomy, preoperatively, as I said you earlier, we can use a GnRH analog to reduce operative time and to restore the hemoglobin level. Misoprostol is usually given 4 hours before surgery so that you can dilate the cervical os, and then you can easily introduce the modulator or the resector scope for doing the surgery. They're commonly used, commonly we can use both. We can use monopolar resector scope, which has a little higher risk because we are using a glycine. A bipolar resector scope can also be used, but in a glycine and a monopolar resector scope, you have a high cutting edge. So the surgery can be done very quickly and completely compared to the bipolar, which is not risky, but it takes extra time. So who are the candidates for doing a hysteroscopic myomectomy? The important message is who are the candidates? The candidates are type 0, 1, and 2. Type 2, submucosal fibroid, you should think whether we can approach hysteroscopically or we may require a laparoscopy. In the type 2, we find by the step W classification, if the size of the fibroid is more than 3 centimeter and it is more into the myometrium, then it's always better to go laparoscopically. So hysteroscopically, what are the contraindication is submucosal fibroid extending the uterine serosa, or it is type 3. And the side effects which we find in hysteroscopic myomectomy is perforation, fluid overload, bleeding, and air embolism, which is one of the rare and disastrous complications. Laparoscopic myomectomy for all patients with subserosal fibroid and symptomatic, and patients who are having an altered anatomy, intramural fibroids, if the size is more than 4 to 5 centimeter, multiple number, and type 2 submucosal fibroid. Laparoscopy has an advantage of degrees moderate short recovery time, better cosmetic results, less blood loss. Disadvantage is comparatively a longer period than open myomectomy. So the step is that how we do the laparoscopic myomectomy, do an incision over the capsule after putting a vasopressin infiltration, dissection of the capsule and removal of the myoma, and you do a multi-layering suturing depending upon the depth of the fibroid which you have removed. So how, after removing the fibroid, how you are going to extract the fibroid out? There are modulators available, like the intraperitoneal modulation we can do, or the extraperitoneal modulation we can do an in-bag containment system. But modulation by in-bag is always better than an open modulation, because the risk of an open modulation with a mechanical modulator is there is a dissemination and disruption of the tissue specimen. Sometimes you may lead up to some surgical complication by injuring to the adjacent organs also. The uterine modulation, you should be, when you're doing it, always do an in-bag, because sometimes if you're going to suspect anything like leiomyomosarcomas, then always the intra-bag or the in-bag modulation is much better. What does the FDA recommend is that always use an intra-bag modulation. Don't use a power modulator, which is an open modulator, because the risk of upgrading the malignancy in cases like leiomyomosarcoma is very high. So in-bag modulation system has a concerns about the long duration of surgery, efficacy, and the limited availability use. So the in-back modulation is always recommended and it is always preferred when you suspect patients with leiomyosarcoma. So other non-surgical managements are available like the uterine artery embolization, HIFU, endometrial ablation, and amylase, which I'm not going to discuss because of non-surgical managements. Coming to fibroid in pregnancy, fibroids prevalence is around 1.6 to 10.7%. Symptoms are usually asymptomatic. Sometimes you find patient with pain and pelvic pressure. Pain is most common when you find the size of the fibroid is more than 5 centimeter. The complication which you find is sometimes like degeneration, the red degeneration, which is more common. Sometimes the patient may go for preterm labors. Malpresentations are common. Abrasions are around 3 to 4 fold and is more with submucosal fibroids and retroperitoneal fibroids. The cesarean, the increased risk of cesarean delivery is more common because of the fibroid in pregnancy, because of the fetal malpresentation, mechanical obstruction, and abruption. So fibroids in pregnancy complications, the main important complication, the disastrous complications, postpartum hemorrhage, fetal growth restrictions. So coming to the management of patients with pre-myomectomy, abnormal placentation, increased blood loss during delivery, and cesarean delivery is always indicated in a patients who has done myomectomy priorly. And when you find more than 50% of the myomectomy is involved during myomectomy, and you find a large defect in the active segment of the uterus, always plan for a cesarean delivery in a patients who have all prior myomectomy. Delivery is usually planned between 37 to 38 weeks of 37 to 38 weeks of pregnancy. And trial of labor can be left for some patients who you find the size of the fibroid is very small and the duration between the previous myomectomy and the pregnancy is higher. Then you can think about doing a trial of labor. But usual recommendation is to go for a cesarean delivery, and it is always done when you find that more than 50% of the myomectomy is involved in the pre-myomectomy section, or also when you find that the cavity of the uterus is open during the pre-myomectomy. When you find a myoma in a pregnancy, some say that we can do, what about cesarean myomectomy? Cesarean myomectomy has an advantage, like you can avoid 2 major surgeries, and if you find a fibroid at the lower uterine segment, you can think about removing the size. But there's always a risk, and usually we don't recommend to remove a fibroid during pregnancy because of the risk of excessive hemorrhage and the risk of peripartum hysterectomy. So surgeon expert is the key to decide whether to do it or not, but usually it is avoided during cesarean section. And my take-home message for today is that submucosal fibroid and cavity distorting the intramural fibroid must be removed to improve the pregnancy rates in infertile women. Fibroids unlikely to cause recurrent miscarriages, even after thorough investigations, 50% of the leiomyoma remain undiagnosed. It is always diagnosed after we get the histopathology report, and we can always plan and do a second surgery. And preoperatively, GnRH and ulipristal may be given to improve the surgery outcomes to reduce the size of the fibroid. Vasopressin and misoprostol are effective in reducing the blood loss during a myomectomy surgery. Modulation should be done very carefully, informing the patient, and always and preferably in-back modulation is better. Myomectomy is a procedure of choice in patients demanding fertility, and other non-surgical managements are available, but its role is not clear. Trial of labor can be given safely for selected patients after myomectomy. Thank you.
Thank you, Dr. Gajadeepan. You have nicely covered every aspect of the surgical management, and I think the guidelines and what are the important points that we have to note is nicely has brought out through your presentation. So thank you very much. Especially you have told about the fibroid removal during the cesarean section. So though there are some recommendation and some people are trying to do that, but always in our setting, going for the second surgery after going for a fibroid removal after the cesarean section is always good, except that in certain situation where the fibroid is very close to the incision, uterine incision, and then if we are not able to close the uterine incision, that time we can think about removal of the fibroid. And also in one other situation, we should always have a plan of how we are going to approach, especially in pregnancy, what incision we are going to make, where we are going to make, whether we have to really go for cesarean classical section, everything has to be thought about in that situation. So thank you very much for your neat and good presentation. And at this outset, I congratulate Dr. MC Patel, Dr. J.M. Kannan, Dr. Saraswati, and Dr. Sharmila to take this forward so that many people will be benefited. Dr. Rajarajeshwari, you want to add anything?
No, madam. Thank you, madam.
Thank you, chairpersons, and thank you for the excellent deliberation on initially on medical management and the second talk on surgical management of fibroid uterus. I now hand over the session to Dr. Monica for coordinating the third session.
Thank you, Dr. Nivedita, and thank you, our speakers, for elaborating the management of fibroid both medically and surgically in a wonderful way. I am sure the delegates will have a very good take-home message. The third session is by none other than Dr. MC Patel, sir himself. I would welcome our chairperson, Dr. Gayatri, madam. She holds a diploma in gynae endoscopy from Kiel. She's a consultant at Shamila Nursing Home, Trichy, an executive member of the Trichy OBGYN Society, and the South Zone Coordinator for Ethics and Medical Legal Committee. Her areas of interest include high-risk obstetrics, infertility, and medical law. She's authored chapters in Foxy Focus and other textbooks. She's also an official reviewer of the International Book of Hypertensive Disease of Pregnancy by ISSHP. We welcome you, ma'am, and we request you to please introduce our speaker, Dr. MC Patel, sir, for today.
Thank you, Dr. Monica. It's a pleasure being here, and I thank Dr. MC Patel for giving me the opportunity to be with all of you on this pleasant evening, and more than that, to chair his personal session. I am indeed very honored to be here to introduce him. And I don't think this happy learning session requires MC Patel sir to be introduced. Let me introduce him as the President Foxy 2028, I guess. Advance and hearty congratulations to you, sir. We all know that he's been a great doctor, great medical legal expert. He's always been there for everyone. But what I'd like to add, which is not there in his CV, is that he's one of the finest human beings I've met. When people go on higher and higher, the way they act, the way they behave with other people, they're kind of, I've always observed some changes or something like that. But sir is so down to earth and so approachable by everybody. So there's none other than sir who can take this topic also ahead and forward. And I don't think the best to work I've always seen is the uniform Foxy consent. And hats off to you for that, sir. Over to you. We are all waiting for your talk.
Thank you. Let me share my screen. Is my screen visible?
Yes, sir, no.
Yes,
Yes,
and
sir.
full screen.
It is full. Yes, sir. It's full screen
Yes,
also, sir.
Okay, fine. So thank you, Gayatri, for kind words. And straight with the topic. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to all the societies who have joined this webinar and all the president and secretary of respective society. At the same time, I would like to thank all the Society of India, Foxy, who have nominated my candidature for post of President Foxy election year 2026. And due to their overwhelming response and love and affection to me and nomination given to my candidature, I have secured highest number of nomination in this election year 2026. So I humbly appeal to endorse my candidature for post of President Foxy election year 2026. Because my commitment is still there Wherever you are, I'll be there. Promise to reach the unreached. And coming to the topic, concept of consent in India, perfect format for consent taking in obstetrics and gynec to prevent litigation. Usually I start any of my talk with this question: is it worth discussing? Yes. If it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. And ignorance of law can never be an excuse, because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. And as far as this consent is concerned, let us understand two words. One is agreement. What is agreement? Every promise and promises forming the consideration for each other is agreement. And when agreement is enforceable by law, then it becomes a contract. And in our medical fraternity, when any patient comes to us, and if we accept her to treat, it becomes a contract or implied contract. We offer our expert services, patient pays for that, or patient promises to pay for that. So it becomes a contract. And under Indian Contract Act, Section 13, when two or more persons agree upon the same thing in the same sense, is a contract. And as far as our medical fraternity part is concerned, it is a voluntary agreement, compliance, or permission without compulsion, where legal validity of it depend upon it being given after understanding clearly what it is for and risk involved. And it is a very famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. In that very case, Supreme Court came up with guideline, or what should be the ideal consent in Indian construct, which should be the criteria for any consent to be valid, were well discussed during this case in Supreme Court. And Supreme Court mentioned consent paper is more than just sign here. So as far as this part is concerned, what is valid consent and which are the criteria for consent to be valid? Very first and important criteria, consent given for unlawful activity is not valid. Even if consent is given, say for example, euthanasia. Passive euthanasia is not permitted in India. Even active euthanasia is also not permitted in India. Even if patient has given consent, then also you cannot entertain euthanasia to that very patient. So consent should be for lawful act only. And who is capable, who is competent to give consent, who can give consent? Any adult who is mentally sound can give consent, but if she is minor and mentally challenged, then guardian will have to sign the document. Can minor give consent for examination? Many a times minor patients are brought to us for examination if she is less than 18. In this situation, can she give consent for examination? Yes. If she is more than 12 years, even though she is minor, in eye of law she is considered as a mature minor, so she can give consent for examination. But at the same time, can she give consent for surgery or procedure? No. So in this situation, consent from guardian will be required. So she can give consent for examination only. She cannot give consent for any intervention, surgical or anesthesia or sedation or so. Can visually challenge give consent? Of course, yes. If she can listen, then we can explain everything to her. And after understanding, if at all any question on part of her, she can ask, we can clarify their query, and she can sign the document. But word of caution here, one guardian should be there as a witness that before me, she was explain everything, and then after she has given signature or consent in this paper. Can deaf and dumb give consent? Of course, yes. If she can read all the document which we can give to her, she can go through. If at all she have any questions, she can write. We can answer those questions and she can sign the document. But again, here also, there will be one guardian as a witness that before us, it was explained to the patient and patient has signed the document. If it is an emergency, no consent required, but burden of proof will be on our shoulder to prove that it was dial emergency and whatever we did, it was just to save life of patient. And all this can be proved by proper documentation. Consent should be voluntary. It should be free, signed by patient or guardian, as per the case may be, and others are witnesses only. If patient is major, if patient is mentally sound, nobody else can give consent on her behalf. Consent should be informed one. So important question, are your patients properly informed? Patient should have knowledge about nature of treatment which you are offering to the patient with all its benefits and side effects. No fraud, no coercion, no false promise at the time of explaining about treatment protocol or treatment modalities which we are offering to the patient. So no fraud, no coercion, no false promise. Available alternative. We have to explain all the available alternative to the patient. Patient is free to choose any one of them, but we can explain her that which is best available alternative in her favor in that very given situation. Say for example, just we were discussing about management of fibroid, medical management and surgical management. If both the alternatives are available, we have to offer both the alternative available. Patient is free to choose, but we can explain which is the best available alternative in her favor in that very given situation. Success rate, particularly in ART practice, we have to explain about success rate also in your clinic, in your city, in state, and in country. But you have not to remember all this. Simply visit Foxy website, and under this title, Foxy Uniform Consent, we have prepared 30 different consents with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consents. You have to simply download those consents and use in your day-to-day practice. Whenever we were preparing those consents, we have prepared those consents in 2 parts. Part 1 is information about surgery or procedure, and part 2 is undertaking. And we have taken based of famous case of Samira Kohli versus Prabha Manchanda, which I mentioned in the beginning. So as far as information about surgery or procedure is concerned, name of procedure, meaning of procedure, purpose or indication, description of procedure, benefit of procedure, alternative, consequences of refusal of procedure, outline substantial risk related to anesthesia, possibility of excessive bleeding or blood accumulation, possibility of infection, injury to surrounding structure during surgery. Every individual has a different way to cope up. So we have mentioned in those concern about scar formation, say for example, keloid formation or so, adhesion formation in future, or in case of cesarean section, scar ectopic, and in case of all other surgery, scar endometriosis. We have mentioned that also. Very rare condition, that is allergic reaction to any drug. We have mentioned that also. And if we are dealing with any obstetric case, then neonatal outcome should also be mentioned about what could be the probable outcome of baby and possibility of need of NICU care we have also mentioned. Part 2 is undertaking. So whatever we have mentioned or explained in part 1, patient will go with undertaking in part 2. But very important part, here it is mentioned in red color. I understand that during course of surgery, doctor may find other unanticipated unhealthy condition that may need specific action, procedure, surgery, and anesthesia. If doctor feels that it will be beneficial to that such condition while performing proposed surgery, and if I am not in a mental or physical capacity to give consent, doctor may take necessary decision. After discussing with Mr. or Mrs., I authorize the above mentioned person to give proxy consent on my behalf. So in this type of situation, we will have to discuss with that very person, and if that person gives consent, it is as good as consent given by patient. So if we have to go beyond the scope of consent given by patient, then we have to approach like this. Patient may give consent like this also. In order to save life, it may even be necessary to do additional surgery or procedure and prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. So if patient has given consent like this, then you have not need to discuss with anybody. We can proceed with surgery beyond the scope of consent given by patient. And at the end, signature or thumb impression, and if it is thumb impression, then it should be attested by a person who is major, mentally sound, and who knows the patient. Two witnesses, one in favor of patient, one in favor of hospital, and signature of doctor is also very much must. Because under Indian Contract Act, unless all the party involved in the contract signs the document, document is incomplete. So whosoever explain patient about this procedure surgery which we are going to go for, consent of that very person, doctor, assistant doctor, or any important part of hospital can sign this document. One more area. Does Supreme Court expect us to talk about all possible complications? So, at the time of deciding this Samira Kohli versus Rafa
Can I expect others except the speaker to keep their phones in mute, please?
or host can also mute them. So to anticipate certain complications and requirement depending upon the condition to the patient, we are under obligation to explain this. And if at the same time, Supreme Court has mentioned no need to explain remote or theoretical risk involved, which may frighten or confuse patient and result in refusal of consent for necessary treatment. Separate consent for anesthesia with all this explanation, nature, benefit, purpose, effects, alternative, and substantial risk. And it is very obvious that anesthesiologist is the best person to explain about all this. So separate consent for anesthesia should be taken by anesthesiologist. Separate consent for blood transfusion. If blood transfusion is managed, plan in advance, then separate consent for blood transfusion is very much required. With all this explanation about purpose, effects, alternative, and substantial risk involved. Because in this particular case, court was very clear that surgery involves risk and blood transfusion involves additional risk. So separate consent for blood transfusion is required. Refusal of treatment. Many times patient is not ready to give consent. Then we are under obligation to explain about need to explain risk of refusal of treatment. But at the same time, court has very specifically mentioned that no need to explain remote or theoretical risk of refusal of treatment, which may pursue the patient to undergo fanciful or unnecessary treatment. So balance should be achieved at the time of explaining about all these probable complications. There could be common consent for diagnostic and operative procedure together. Say, for example, operative laparoscopy and ovarian drilling. So this way we can do this. Particular surgical procedure and additional or further procedure. Say, for example, cesarean and tubal ligation, cesarean and myomectomy, hysterectomy and salpingo-oophorectomy. So particular surgery and additional surgery, we can go with common consent. Consent given for specific treatment cannot do other procedure unless it is life-saving. An argument that it was beneficial, would save time, would save pain and suffering in future doesn't stand in court of law. So you cannot go beyond the scope of consent given by patient unless it is life-threatening condition. Let us see in this particular case, consent was given for diagnostic laparoscopy and doctor went with diagnostic laparoscopy and ovarian drilling and salpingectomy for which consent was not given. So case was decided in favor of patient and compensation of 25,000 plus 2,000 was awarded in favor of patient. In this particular case, it was case of DUB, previous two LSCS, and patient was for total abdominal hysterectomy. So consent was given for total abdominal hysterectomy. But on table, after anesthesia, doctor went with vaginal hysterectomy. And during course of surgery, at the time of ovarian stump, there was profuse bleeding because as such, it was injury to blood vessels of pelvic kidney. There was pelvic kidney and blood vessels were very severely damaged and there was profuse bleeding. So ultimately laparotomy was done, and in spite of all their care and caution, bleeding was not getting control. So that pelvic kidney was removed. Patient was lucky that she had one more normal situated, well functioning kidney. Case was filed, and during deciding this case, court was very clear that bleeding is no negligence. Bleeding may occur at any time, at any place by anybody, but he should manage that part. And in this particular case, bleeding part was well managed, but deviation from route not acceptable because in this case, consent was given for abdominal hysterectomy and he went with vaginal hysterectomy after anesthesia. So case was decided against doctor and compensation of ₹5 lakhs was awarded in favor of patient. Should consent be written? Is it mandatory? So by law, there are three conditions in which written consent is very much mandatory. Organ transplantation, under PCPNDT Act, sonography of antenatal patient, and medical termination of pregnancy under MTP Act. In these three conditions, written consent is very much mandatory. In all other conditions, consent can be oral, but burden of proof is on your shoulder to prove. And in so many cases, patient may go hostile that I never give consent, I didn't give consent, doctor didn't explain anything to me. So though it is not mandatory to be consent written except these three conditions, but it is always advisable to go for written consent. Consent can be taken by assistant doctor also. Can it be taken in pre-printed form? Of course, yes. Because in one famous case of RG Stone Hospital versus Vinod Agarwal was HIV positive patient. He had some urological problem. Many hospitals refuses to get him admitted and operated due to his HIV status. RG Stone Hospital became ready. He was admitted. He was operated. Operation and post-operative period was totally uneventful. Patient was discharged in due course. In spite of all this, patient filed a complaint against hospital that my consent was taken on pre-printed form, and to take consent on pre-printed form is unfair trade practice. So in this particular case, unluckily, in National Commission, case was decided against RG Stone Hospital and compensation of ₹10 lakhs was awarded to patient Vinod Agarwal. RG Stone Hospital was ready to pay that amount and they were not at all interested to prefer appeal challenging this judgment. And at that time, we were preparing Foxy uniform consent. So one of our team member, Dr. Nikhil Datar, approached RG Stone Hospital, convinced them to prefer appeal in higher fora because we were worried if this judgment was not challenged, then in our day-to-day practice, either we would have to take consent in handwriting of patient or in handwriting of surgeon or in handwriting of assistant surgeon or so. So we could convince RG Stone Hospital and appeal was preferred. At the time of tabling this appeal before higher fora, our argument was, what is unfair trade practice? Any unfair means to promote business is unfair trade practice. And in our medical practice, if we take consent in pre-printed form, or if we take consent in handwriting of patient, in handwriting of surgeon, or in handwriting of assistant, can it enhance our practice? And court was convinced. So this case is allowed. Still case yet to be decided, but stay is granted and till final judgment. Of course, we are very much hopeful that judgment will be in our favor, we can have consent on pre-printed form also. Should it be in English or vernacular language? It is always preferred to be in vernacular language. But if at all it is in English or any other language which patient couldn't understand, then at the end of consent, if patient writes like this, that whatever written above was explained to me in language which I could understand, I was answered all the questions which I had, and then after I have signed the document. And one of the relatives signs the document as a witness that before us, it was explained to the patient in language which patient could understand, and then after patient has signed the document before me. So in this situation, consent in any other language also very much valid in eye of law. Should it be who should sign the consent? Just I mentioned prior also, patient, or in case of minor guardian, two witnesses, one in favor of patient, one in favor of hospital. Should doctor sign the consent? I mentioned prior also, yes. Hysterectomy with salpingectomy, hysterectomy with salpingo-oophorectomy, cesarean with myomectomy, cesarean with tubal ligation. You can very well go with prior consent, but prior consent for all those additional surgery should be there. Can we allow attendee during surgery? Can we record surgery? Can we display surgery during this type of webinar or CME or in teaching institution? So in all these conditions, prior consent from patient is very much must. And when we are displaying any surgery, that personal identity of patient should not be revealed. So we should be very careful with prior consent, and confidentiality of patient should be concerned. Obstetric sonography. Under PCPNDT Act, consent of patient is very much mandatory, and we have to take that very concern. If we are dealing with invasive procedure under PCPNDT Act, then we have to take consent in Form G. It is prescribed form, and in that very form, we have to take consent of patient if we are going for invasive procedure like amniocentesis, chordocentesis, chorion venous sampling, or any invasive procedure under PCPNDT Act. And this is one more prescribed form, that is Form C, and it is very much mandatory in case of MTP. We have to take consent in Form C. It is very much mandatory, but this is very simple consent. So here what she has written, I do hereby give my consent to terminate my pregnancy. So it is very simple consent. It is not informed consent. So in this situation, you will go with two consent. One in this Form C, which is mandatory by law, and one informed consent as we take in any other surgery or procedure. And for that also, you have to simply download uniform consent from Foxy. We have prepared two separate consent: termination of pregnancy by medical method, termination of pregnancy by surgical method. You can download and use in your day-to-day practice. If patient is minor, that in that very Form C, in part 2, guardian will sign the document. So minor and mentally challenged, guardian will sign the document. Consent to be maintained in ART practice. So again, they are prescribed consent given by law also. So by couple or all the party involved in the ART program will have to sign the document. And we will explain about all the probable complications or side effects like nausea, headache, abdominal bloating, ovarian hyperstimulation also should be explained to the patient. And we have to mention about possibility of ovarian response to be poor or absent, and we have to consider cancellation of cycle should also be explained during ART treatment. Further, we cannot give guarantee about ovulation or ovum formation or embryo formation or chemical pregnancy formation or genetic pregnancy or carry home baby. So we cannot give any kind of guarantee. We have to explain everything about this and all the risk involved in aspiration of ovum, and patient is free to withdraw consent at any stage of treatment before we transfer.
বাথরুমে কালকে রাতে
time.
অনেকগুলো দিয়েছি মা,
So we should be very clear at the time
অনেকগুলো
of
দিয়েছি,
DRT.
অনেকগুলো বিরাট।
Possibility of multiple pregnancy, ectopic pregnancy, miscarriage, fetal abnormality. We have to give all this to the patient as far as this explanation is concerned. Possibility of multiple pregnancy also we have to explain. So if we have explained everything and if patient signs the document, it becomes a very good document in our favor. Withdrawal consent, just I mentioned prior. And in this particular case of C. Jaipal Reddy versus Padmini Velluri, in that very case, National Commission has very specifically mentioned that consent is not mere piece of paper on which patient or relative has to sign, but it is a very important document of your communication or of your counseling. So whatever you counsel, whatever you communicate, it should be entered into consent paper, and then patient has to sign the document. And once patient signs the document, it becomes a documentation of communication. So whatever you have communicated is documented by signature of patient. So to conclude, this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way. So if you want to sleep like this, take tender care of your patient, take valid consent, comply with the provision of law, pray Almighty God before going to sleep, and keep my visiting card below your pillow. And to conclude with humble appeal to endorse my candidature for post of President Foxy, election year 2026. Voting will be from 1st August to 10 August 5 p.m. Please exercise your right of voting. Please vote in my favor and makes other also to vote for me. With regard, thank you, salute to all the convener, coordinator, and all the president and secretary of joining society. Thank you very much. Please do not assume. Please ask if any query, any question, if chairperson and time permits. Thank you very much.
That was total and complete, sir, as always expected from you. And apart from this, I can't think of many doubts. Does anyone have to ask anything? Sharmila ma'am?
Actually, like they say, you should not have a consent which is already prepared, no? So for every case, are we supposed
Not now, ma'am. Not the cases yet to be decided, ma'am.
Let me clear. Consent should be procedure and surgery specific. Okay. So consent for cesarean cannot be the same consent for hysterectomy. Okay. And in this uniform consent, we have prepared 30 different consent that way only. And in part 1, say for the example, if it is for cesarean section, we have explained everything related to cesarean. If it is for hysterectomy, then we have explained everything about hysterectomy. Okay. And we have prepared 3 different consent. For abdominal, for vaginal, and for endoscopy. So that we have prepared consent. So though it is in pre-printed form, but it is not uniform in that way. It is not one and same for all the procedure or surgery. It is different for each and every procedure and surgery. And it is very much valid in eye of law.
Yes, sir. Got it.
Sir, good. Sir, one doubt, sir.
Yes.
It should be handwritten or it can be typed.
No, just I mentioned, and I discussed that case of Vinod Agarwal versus RG Stone Hospital. You can be, if you are comfortable in your own handwriting, fine. But you can use pre-printed consent form. You can download from your computer also. But each and every important point should be there in that very consent form, and it should be explained to the patient.
Yes. Thank you, sir.
Yes.
Thank you very much, sir.
Thank you, sir.
Yes, Gayatri.
Thank you, sir. Thank you very much for the elaborate speech on consent. And I'm sure whenever we have doubt, we can always reach out to you. As I said, you will always back us up and you'll always be there for us. Thank you very much, sir. And advance congratulations and all the best.
Thank you. Thank you very much.
Can we go on to the panel? Monica?
Oh, yes. Oh, yes.
Yes, ma'am.
Monica,
Yes, ma'am.
Sadapti,
Yes, sir.
Sadapti, please introduce.
Yes, yes, sir. Yes.
Saraswati madam's phone has to
Anika-
be muted. It is causing disturbance. Saraswati madam, please mute yourself. Yeah. Saraswati, start.
Okay, we'll move on to the panel discussion. We have a very interesting panel discussion coming up on ovulation induction. It's to be moderated by Dr. Charmila ma'am and Dr. Anita ma'am. And the expert for the session is Dr. Vijaya Prabha ma'am. So Dr. Vijaya Prabha ma'am is a consultant obstetrician at Shakti Hospital at Lalgudi, Trichy. Also the executive member of Practical Obstetric Committee and secretary of the Trio GS. Welcome, ma'am. Our first moderator is Dr. Chamila ma'am. We all know Chamila ma'am is the president of the Trichy Obs-Gynae Society, has been the vice president of FOXY, and currently is also the vice president of the Osteoporosis Society and Gestosis India Association secretary. Welcome, ma'am.
Thank you.
Our next moderator is Dr. Anita ma'am. Dr. Anita ma'am is a consultant at Pudukkottai Hospital. She's done many CMEs and ECMEs and also the secretary of the Pudukkottai Obs-Gynae Society and president of IMA Pudukkottai. Welcome, ma'am. We have
Thank you,
7
ma'am.
panelists with us. Yeah, welcome, ma'am. Our first panelist is Dr. Uma Brinda, ma'am. Dr. Uma is a high-risk obstetrician and gynae endoscopy surgeon. Ma'am is a senior consultant at Rio Hospitals at Thanjavur. Welcome, ma'am. Then we have with us Dr. Pushpalata Kumari, ma'am. Dr. Pushpalata Kumari is an associate professor in the Department of OBGY at CMC Vellore. And her special areas of interest are general gynecology, endometriosis, urogynecology, menopause, and minimally invasive surgery. Welcome, ma'am. Next, we have with us Dr. Surya Prakash Murthy. Ma'am is a member of the Royal College of Obstetrician of London, has advanced diploma in minimally invasive surgery, and is the member of various associations. Welcome, ma'am. Then we have with us Dr. Renju. Dr. Renju is a consultant at Arunagiri Hospital at Dharmapuram. She has been the faculty in various national and state conferences and has been the former joint secretary of Erode Obs-Gynae Society. Welcome, Dr. Renju. Next, we have with us Dr. Chitra ma'am. Dr. Chitra ma'am is a consultant at Thanjavur. She has a fellowship at GG Hospital under Dr. Kamla Selvaraj in Chennai and also has been trained in laparoscopy at the World Laparoscopy Hospital. Welcome, ma'am. Next, we have with us Dr. Vijitra ma'am. Dr. Vijitra is a consultant at Vijay Hospital at Karur and also the secretary of the Karur Obs-Gynae Society. Welcome, ma'am. Last but not the least, we have with us Dr. Vindhya Lakshmi. Dr. Vindhya Lakshmi is a consultant at Excella Gynae Care Women's Specialty Center, Coimbatore. She also is the committee member of IAEC as well as FOXY and of the FOXY Clinical Research Committee and PCOS Society of India. Welcome, Vindhya Lakshmi, ma'am. Over to you, Charmila ma'am and Anita ma'am.
Yeah.
Yeah.
Can you stop sharing? Yeah. Thank you so much, Sadapti, for that very kind introduction. I would like to welcome all the panelists and the moderator, my co-moderator. 1 second, I'll just share again. So Anita is the secretary from Pudukkottai Society, and she's infertility specialist as well as high-risk obstetrician. So we will be co-moderating the panel. We have taken ovulation induction PCOS as the topic because ovarian stimulation is something different from ovulation induction. I'd like to welcome the expert, Dr. Vijay Prabhachelian, the secretary of the Trichy OG Society. Respected panelists, Dr. Uma Brinda from Thanjavur, Dr. Pushpalata Kumari, Dr. Surya Prakash Murthy, Dr. Renju, Dr. Chitra Selvamani, Dr. Vijitra, and Dr. Vidya Lakshmi. So the first patient, I would like to ask Dr. Uma if she's there. Uma, you're joined. Uma. Pushpalata madam is there. Pushpalata madam. She has joined? No. So we'll have Dr. Okay, ma'am. Okay. So this patient is 29 years old. She's attained a menarche at the age of 11, has got irregular cycles on and off, In the last 1 year, her menstrual cycle has been like once in 50 to 60 days, and the flow is for 5 to 7 days. This lady has been married for 2 years, and she has come for a primary infertility evaluation and management. On examination, vitals within normal limits. Her BMI is 24. Has got mild hirsutism, has got acanthosis nigricans, but does not have a goiter. Investigations, complete blood count is within normal limits. Thyroid profile is normal. Prolactin within normal limits. The GCT was 130. Ultrasound shows a PCOM morphology. Male factors were within normal limits. So can I ask Dr. Pushpa, ovulation induction is correct because she has come for infertility?
Yes, ma'am.
What is the
Yeah,
drug you
because
prefer, clomiphene citrate or letrozole?
Yeah, so basically she has the feature of hyperandrogenism. She's having a, uh, she's not obese, BMI is on 24, but she had the feature of hyperandrogenism. So definitely she need this one, ovulation induction. So
what is the drug you prefer, letrozole or clomiphene?
Yeah, I prefer letrozole because this is the first line of management for the ovulation induction currently.
What is the dose you
And,
will start and what day will you start?
Yeah, we are starting with 5 milligram once daily for day 5 to day 10, and then we have to monitor the fetal
So you will give it for, if you're starting on day, what is the day you will start? Letrozole?
We'll start from day 5 only, ma'am.
Day 5 only. Anybody would like to start on day 2 to day 3? Any of the panelists? Why day 5?
Yes, ma'am.
Yeah. Vidya?
I generally start from day 2 or day 3, either day 2 to day 6 or day 3 to day 7. I give.
What is the logic? Why day 2, day 3 and one group is day 5? Is there a logic to that? Anybody has thought about it?
Ma'am, before good evening, ma'am.
Yes, Surya.
Basically, the concept behind starting on day 3 on day 5 is getting more of FSH and increasing the FSH threshold. So day 2 on day 3, the FSH levels would be low.
Okay.
So once it starts and day 4 and day 5 the rise, so people want to keep the threshold little above for the PCOS.
Okay.
So like most of the follicles would be already in an arrested phase.
Okay.
So they want some more little push of FSH so that they become increased
So
level.
how does letrozole work? It is actually an anti-estrogen, right? So it,
so
it's
an
aromatase
inhibitor.
So
Letrozole acts on the ovary. Clomid acts on the central level.
Central system.
So
Yeah.
what happens with the letrozole? Letrozole blocks the inhibitor, like
Okay.
aromatase inhibitor. So
Okay.
the estradiol production gets cut off, and the androgen is elevated.
Yeah.
That acts as a negative feedback. It gives the signal as though the estradiol production has been cut off. So the FSH rises. That's the mechanism behind starting letrozole.
So why day 2, day 3 to day 5 is important there?
Yes, ma'am. Basically, on day 2 or day 3, there is a basal level of FSH.
Okay.
So what happens? Initial, the FSH cohort start raises.
Okay.
Automatically, all the atretic follicle, the initial phase of recruitment, selection, and dominance starts from day 2.
Okay.
So the ideology behind starting on day 2 rather than starting day 5 is, if we start on the day 2, already the FSH is on the lower level. If we put the letrozole to that particular patient on day 3 and day 4, her FSH starts raising since it gives the signal of absence of estradiol.
Okay.
If we start them by day 5 or day 6, as madam said, then automatically her basal level of FSH starts raising from day 2, day 3. And from day 5, it pushes above the threshold. And that will have little beneficial effect if we start on day 3 or day 4 rather than starting on day 2. That would be helpful in PCOS.
Are there any studies to say that you will have a better ovulation rate compared to day 3 and day 5? Are there studies to back it up?
There are no recommended studies or enough proven large studies.
That is the point I'm coming to. See,
yes, it is all or depends on the practical experience. But none of the recommendations say that start on day 2, start on day 5.
So, okay. Yeah, see, that's what I'm coming to. See, as Dr. Pushpalata said, she's right in starting on day 5. There's nothing wrong. Day 2 to day 3 is also perfectly fine. The only thing is because these patients are PCOS, so when you're going to bring down the estrogen level, the FSH starts rising and it starts the recruitment of follicles and it happens. So don't think that like starting on day 2, day 3 and day 5 makes a difference. It's almost the same. And the dose which Dr. Pushpalata was talking on 5 milligram. 5 milligram is a dose, but most of the Indian population responds to. But the guideline is only for 2.5 milligram. So suppose you have a medico-legal problem, as Dr. MC sir was talking, and you have had a patient on 5 milligram of letrozole and she has a problem, you may be sued. Because the guideline by the DCGI is only for 2.5 milligram of letrozole. So there is a case going on in Delhi. So what we always say is, when you give 2.5 milligram for 5 days, no problem. If you're going to increase at 5 milligram, actually it is ideal that you get a consent. You know that? That we always, we thought we are giving correctly, but yeah, when you want to increase a dose, it's better that you get a consent from the patient that she may not respond to the 2.5 milligram OD, because most of them responded 5 milligram and for an extended duration. So you have to get actually a consent. Dr. Vijay Prabha, Dr. Anita can say something on that. Senior people.
Yeah, always start with the lower dose. Always start with the lower dose.
2.5.
Then we can, if there is no response, then we can increase the dose.
Yeah.
So 2.5 is the basic dose.
Basic dose.
So always you have to better. It is always to start with the lower dose. This is like recruiting more follicles. When we increase the dose at the first initial step itself, then more follicles will be recruited and more follicles will be destroyed. So you start with the lower dose, then you can increase the dose.
Yeah.
If there is no response,
trial cycle
you can go in
should be
for
done.
extended regimen.
One trial cycle should be always be done to see at what
Obviously,
dose the patient responds. Don't jump in, because she's a naive patient. She's never had ovulation induction earlier. So probably a 2.5 milligram OD also she can respond. So don't jump into 5 and extend it for 7-10 days, which many of us do. Dr. Vijay Prabha, would you like to comment on that? The dose?
Starting letrozole on day 2 is better, because you can when you want to add gonadotrophins,
Yeah,
can titrate the dose better, and you also have an idea about how the cycle is going. If you're going to start at day 5, then you may not be able to get the idea of how the follicles are being recruited.
Okay, right.
So starting on day 2 is always better.
Better. Okay. So clomiphene
but she had that androgenic feature.
Yes, ma'am. Yes, Dr.
Yeah,
Pushpa.
but she had the androgenic feature. She's so that we have to compensate for that having the ovulation
See,
induction.
androgenism
She
is a
doesn't had any androgenic feature.
hyperandrogenism is a part of PMOS that we have to accept. So you need to treat her androgenism only if she complains of that. You are noticing that hirsutism means you need not offer her a treatment. She has to say, I'm having a problem with this hirsutism and acne, whatever, then you treat. Otherwise, any PMOS patient will have that hirsutism. If you think you can bring down that hirsutism and then put her on an ovulation induction for infertility, may not be very viable, because she has come to you for infertility. She's not complaining about a hirsutism now. So if she complains, then her treatment will be totally towards that, and you cannot give her a fertility option at all. That will take months or years together for the hirsutism to come down to her, whatever she wants. So this is particularly for fertility, Dr. Pushpa. So we are not getting into the hirsutism at all. Hirsutism is a part of anyway polycystic ovary syndrome. So we know that clomiphene is a drug which historically has been used. It's started at 50 milligram day 2 to day 5. And only when the ovulation is not documented, you will increase to 100, 150 and whatever. And according to practice committee of ASRM, the American Society, if you document ovulation, you should give for 6 cycles of therapy, and 60 to 85% is the ovulation rate with clomiphene, and it translates to a pregnancy rate of 40 to 50%. Initially, letrozole was not accepted as an ovulation induction drug, but it has got advantages of not interfering with the endometrial development and is quite effective in obese patients. And the biggest advantage is it can give you a monofollicular development and prevent both the development of multiple pregnancy as well as sometimes OHS. So that's why letrozole is now considered as a first-line therapy at 2.5 to 5, but there are guidelines by DCGA which says 2.5 is the dose you will start with. So this we have already covered. Or what day the cycle also we did. How many days? Like 5 days if you're given. Who made that 5 days as a method? Like, can I ask Renju? Renju is there?
Ma'am, the dominant follicle usually is selected by day 6 or 7, ma'am. So
actually,
maybe
I'm trying
that
to
is the...
confuse the panelists so that each one of you fight with the other. I don't want everybody to agree with each other. Yeah. So like, see, 5 days is what everybody says. Why do you think 7 days is wrong? Why can't you give for 7 days? Yeah.
Ma'am, there is no universal recommendation for 5 days. it is like a by from even nowadays they say if the women does not respond for 5 days, we can extend the
No, that is
protocol.
all the protocol after that. But why did they start at 5 days? That's what Renju I wanted to answer. Renju, yeah.
Ma'am, clomiphene citrate also, it was like for 5 days.
That's what, who fixed up that 5 days? Any idea?
No, ma'am.
Actually, there's nothing like 5 days. Somebody did one study with 5 days and they got a result and they said 5 days is okay. But actually, it's arbitrary. There's nothing like 5 days worked much better than 7 days or 8 days. So now that 5 days is now taken off and you can go for an extended duration of therapy also. And when you want to compare both the drug, is this I've already told you. So this number of days is actually arbitrary. There's no study to back up saying that 5 days is much better than 7 or 8 days. So we start for this patient. So can I ask Dr. Chitra madam, like when will you do the ultrasound after you given 2.5 milligram of letrozole for 5 days? Chitra madam?
Ma'am, she has not joined, I think.
Vijitra then? Dr. Vijitra? Dr. Vijitra? She's there? Dr. Vijitra has joined? No. Vidya?
Yes, start the ultrasound monitoring from day 9 or day 10, ma'am.
Okay.
From then on, I track
This
calculating
patient does not have a
centimeters per
follicle of
day.
size 10 mm. So what will you do now? You have tracked her with an ultrasound.
In that case, I would like to continue letrozole, madam.
How much you will give?
The same dose. If she was already on 2.5 milligram once daily, I would continue the same dose. And sometimes it is also pertinent to step up the dose to 5
No.
milligram.
Now what you will do? The patient is asking you now. She's sitting in your OP.
Now I will make it 5 milligram per day and continue it for another 3 more days
That
and
you
follow
can do
her.
only next time, next cycle. No, this cycle.
No, this cycle itself, they can be done, Anita. That's what the newer guidelines have come.
I will do an extended letrozole protocol in the same cycle.
What is the
without
dose
waiting.
you will give? No, what is the dose? You said to a 2.5 and then you said 5. So what is the dose you will give for such a patient?
I am generally going with 5 milligram.
5
ma'am,
milligram,
and
how many days you will
7 to
give?
10.
How many days?
Another 5 days. Another 5 days. I
And
take.
then when will you call her for the ultrasound, next ultrasound?
The next ultrasound, I do it 3 days later or 3 to 5 days later, depending upon
No,
her
you have to
previous
give up.
response.
That patient won't accept if you say, if you want, you come on 3rd day. If you want, you come on 5th day and all. So you have to tell her very clearly what day you'll call her.
Maybe I'll see her 3 days later.
No, your regime now is you're given 2.5 5 days, 10th day done an ultrasound, no dominant follicle has grown, so you're going to increase your dose. So you're given 5 milligram. You're going to give for 5 days. So when will you call her for the ultrasound?
Another 5 days after she finishes the dose.
No, at once or 3rd day or 5th day?
The 5th day, ma'am.
After she finishes, the next day you will call. Okay.
The 5th day of the dose I call.
That is when she's finishing her letrozole tablet, she has to come for the scan. Surya. Surya.
Ma'am, I would add gondotropin for her.
You will go for how much of dose you will give gondotropin?
Depending upon her BMI, either
She's 24 BMI. 24 BMI.
It's 75. 75 on day 10.
How
on
many
day
days you will
11
give?
and day 12. Again, I'll do a scan on day 13.
Okay, so 3 days of 75 milligram of gonadotropin and you'll do a scan the next day after
Day
that.
13.
Okay, and Dr. Pushpalata?
Yeah, I also think that it's gonadotropin is better because
Okay. How much of gonadotropin for how many days and when will you call for an ultrasound?
75 milligram. Then we have to call for ultrasound by at least by day 12, day 11 to day 12.
So Surya said on 13th day you will call her on the 12th day itself. Because 10 and 11 you are given gonadotropin and 12th day you will call for a scan. Okay. And Surya
So
said.
I would actually, I have seen
The expert has to say at the end.
Yeah,
we are waiting for you. Okay. So we are finished with Surya. We are finished with Dr. Pushpalata. Renju.
Ma'am, I'll continue with the same dose, 2.5 mg for another 5 days. And once the dose is completed, I'll call her back again, ma'am.
On the next day itself, you will call. You will not wait for a period of time.
Ma'am, 2.5 for another 5 days, call her back on the 6th day, ma'am.
Okay.
Once the dose is completed.
Okay. Anita?
Yeah.
Gonadotropins, yeah.
Yeah, gonadotropins. I'll go in for gonadotropins.
How much you will give?
For 3 days, if I have 75 is enough. And after finishing the third dose, fourth day we'll go ask her for
something similar to what Dr. Surya said, right? Okay. Expert. So all five have said different ways. So you have to tell us what is right now.
Yeah, actually, in this, what is the BMI?
24.
24, but she has mild features of PCOS.
Hirsutism, yeah. Androgenism she has.
Yeah, I've observed in some patients that I usually start with 5 milligram from day 2 to day 5.
No, this patient we have started on 2.5. You are not given 5 at all. And she has not responded. So, okay, 5 she has given, not responded.
Okay, 5 if I wait for some time. See, this is the first cycle, just monitor. Sometimes the patient develops the follicle late.
So you will not give anything and call her after how many days?
Anything. I will follow her up. I'll ask her to come. If she's on day 10, I'll ask her to come after 3 days. And many a time I find that the follicle develops late on day 15, day 16. Sometimes the dominant follicle grows.
Okay.
And even these patients have conceived. So first cycle, don't push her onto gonadotrophins or anything. Just wait, observe her. And then the next, if she doesn't conceive, the next cycle, then you can add gonadotrophins.
Okay. Everybody is different. See, so there is nothing like one size fits all.
Yes, ma'am.
So
Here her
okay,
cycle
we'll
is
get into
60
that
days.
later, like all the protocols, because all the protocols are coming as guidelines in the later slides. So suppose you want to label a patient as letrozole resistance. When would you do that? Surya?
Ma'am, resistance is no ovulation at all in spite of increasing the dose. And the failure is ovulation has happened, but she has not conceived.
Now, how many cycles you would say you would give ovulation induction and then say she's having a failure?
3 to 4 cycles.
6 cycles.
6 cycles.
6 cycles she's had ovulation, but she has not conceived. Then you are labeling her as letrozole or clomiphene failure. So how do you treat this resistance or failure?
By adding gonadotrophins.
Okay, so your choice is gonadotropins. If clomiphene, letrozole would have been the choice, and ovarian drilling. How many would like to do drilling for this patient if she has not responded to your whatever combination you have given? Anita would do drilling?
No, I'll wait. I'll ask her for my lifestyle modification. I'll give some more time. Wait, we are given for 6 cycles. I'll give a period of rest, at least for 2 cycles. Then only we'll think of.
Okay. And like how many drilling are you doing in a 6-month period? How many patients come for drilling after you finish your induction and all that, and still you find that you can do a drilling? Any patients like that? How many are you able to do now?
Mom, nowadays we have reduced thinking about drilling.
Very less it's come now compared to earlier, because they respond usually to some form of difference and changes in regime.
The patients whom we have to go for drilling is the lean PCOS.
Lean PCOS, because a lean PCOS, that is a thin patient, a patient who's having a short period of infertility, a patient who's of younger age, and a patient who's having a high LH. These patients will be good for drilling. Yeah. Yes.
It's like refractory to all kind of medical treatment.
Then you'll go for drilling. Okay. So this difference between ovulation induction and ovarian stimulation, we know, right? Ovarian stimulation is for IVF. It's not for a patient who's having anovulatory cycles. So what is the protocol for ovulation induction? This, I think all of you had said. Would you like to give FSH or HMG when you give a gonadotropins?
It's HMG.
It's HMG we generally prefer during for natural as well as the IUI cycle, mainly for the cost for
the
reducing
patient
the
is
cost for the
Ambani's
patient.
family. What will you give?
Even then HMG.
RFSH.
No, actually, when we
studies have shown both are equal.
Both
have the same response.
Follicle first with the day 2 FSH and then give HMG, the results are better.
Okay, how much of FSH will give HMG get better?
Day 2, 150 FSH.
150.
Yeah, and day either it is 456 or 567. It is HMG 75 or 150.
You start with FSH and then switch over to HMG.
HMG, the priming
so
with
many
FSH.
new protocols are coming.
Yeah, it's good.
But the studies have shown both FSH as well as HMG have the same results.
Equal.
Success rate is better.
Equal results.
Primed with FSH or IUI cycle.
And when you actually have little HCG, this also gives very good results actually with the HMG. Yeah. So there's actually no difference between urinary or recombinant gonadotropin, even if it's Ambani, as Anita said. And only when you have a OHSS risk, you will go for an agonist trigger. Otherwise, you can give HCG if there are 1 or 2 follicles. And what they said, if the patient is insulin resistant, they will require higher doses of gonadotropin. So don't think that thin patients will need lesser gonadotropin and the obese patient will need more. It is actually the insulin resistance which will decide the dosage of gonadotropins to the patient when they respond. So what are the disadvantages? We know the cost, and the most important problems is multiple pregnancy, OHSS. And sometimes if all this risk is happening, you need to shift her to an IVF cycle because too much of follicles would have grown. And the sequential therapy, I think Vijay Prabha was talking on. She will give letrozole and then add gonadotropins. So actually it has good results. It's quite superior to just giving ovulation induction with letrozole alone. Adding a sequential injection with HMG works in a big group of patients, and that was a 2023 study in reproductive biomedicine online. So alternative protocols is the one which I want to touch upon, which I think Vidya Lakshmi and Renju had talked upon. Actually, now we don't even use much of gonadotropins because these extended protocols and increasing doses have caused a big revolution as far as ovulation induction PCOS is concerned. And this, as I said, this extended regime of 8 days is actually very effective in almost 50% of the cases. So when you have a patient who is not responding to a 2.5 milligram OD, you can either increase to 5 milligram or 2.5. There's actually no consensus on saying 2.5 is better or 5 is better when you add as a step ladder pattern. It's called the staircase protocol of letrozole. So you can first give 2.5 and then increase to 5. But ideally, your follicular monitoring should happen 3 to 5 days after the last dose of letrozole is over. Because if you want to see the response, don't do the ultrasound on the next day itself because many times the response may not happen. So this was one big study which has given a clear picture of how the staircase protocol of letrozole works. So in one group, they gave the traditional dose of 2.5 for 5 days. The second group, they gave 2.5 for 10 days. Third group, they gave 5 milligram for 5 days. And the fourth group, they gave 5 milligram for 10 days. And they said, except the group 1, 2, 3, and 4 showed a much better ovulation induction rate as well as a pregnancy. So it's worthwhile doing these regime. And this also has come out in the recent study in fertility sterility where they have said a 5 milligram dose or extending to a 10-day course rather than the 5 days will give a much better pregnancy rate. So these are the stair-step protocols, which I think I've already talked upon. So when you want to compare between clomiphene and letrozole, definitely letrozole is much better as a stair-step. And here you will start at 2.5 milligram, then you can go up to 5, and actually you can go up to 7.5 also. And when you want to do the ultrasound, it should be done 5 to 7 days after the last pill. And still, if you don't have a response, then you will add at a higher dose and then repeat again. And many patients, actually one of our fellows has done a study on that, and we are showing a much better pregnancy rate with the stair-step protocol. So suppose there's a logical thought that when you go for a higher dose for an extended regime, will it lead on to a multifollicular development or a multiple pregnancy when you're using even letrozole? But that does not happen. So you need not worry about it. When we give it higher dose or repeated cycles, it may not happen. And single dose for letrozole, how many have tried? Because suppose a patient comes on day 5, day 6, some have got a logic of giving all the letrozole in a single day. How many have tried that?
No.
No.
Actually, it's a good regime, actually. You can give 25 milligram single day on day 6 or day 7. And they say, and we have seen also good results. It has got a good compliance because patient need not take it every day. So 5 milligram combined together in a 25 milligram dose we have given, and that also, yes, gives a good result. And will you do any ovarian reserve test before you start on ovulation induction IVF? How many do IVF? Anita has got an IVF unit?
No, madam.
Oh. So Surya has got. So Surya,
Ma'am,
will you do any ovarian reserve test before you start ovulation induction in a patient who's going for an IVF?
ma'am, if it is for IVF, then I would do.
You will do. What is the test you will do?
AMH and AFC.
AFC. So how will you change your protocol if you see a high AMH or high AFC?
Ma'am, if it is a PCO with high AMH, high AFC, young age, then it is low dose gonadotropin, like minimal stimulation.
How much?
Starting is 150.
150 you will start.
150.
Dr. Pushpalata has got an IVF unit. Dr. Pushpa? She's there, Dr. Pushpa? Dr. Pushpalata?
Yes, madam.
Now you have an IVF unit, doctor?
No, we are actually working as a gynae in the reproductive medicine as a separate unit.
Okay.
So, yeah.
Okay. So AFC and AMH can be done. Then that will tell you whether she's going to respond to a ovarian stimulation in what way. So what are the preferred protocols? I think Surya, you can answer. We can. Yeah.
It's always
Antag, always Antag.
Antag and minimal stimulation protocol and freeze all approach.
Okay. Yes. Perfect. And agonist protocols, if you give, you have to give at a lower dose and to reduce the risk of OHSS if you're going for a long agonist protocol. And like, can you combine letrozole or clomiphene when a patient is going for this thing, IVF, PCOS patient? Oral ovulogins in IVF for IUI.
Few would add clomiphene also along with the initial phase of FSH.
Okay.
But we won't usually do. It's only
use
rec
only
FSH.
gonadotropins. Yeah. What is the trigger you will use during IVF in PCOS patient?
An agonist trigger is always preferred.
Yes. Vidya's got an IVF unit.
I do IVF. I don't have my own center.
Oh, okay. Sorry, I didn't see that. Sorry. Yes. Okay, so the trigger you will give is always GnRH agonist and not a HCG trigger, because that can cause an OHSS. So this is the take-home message, I would say. A starting dose of 2.5 milligram for 5 days may lead to an inferior response rate for ovulation induction. So the only thing is you get a concern for a higher dose or an extended duration you can give. And if the patient does not respond to the initial letrozole regime, they can be redosed or something called stair-stepped. The reduction in time to achieve ovulation may translate to a reduced time to pregnancy, and patients can complete more cycles within a given time period. During IVF, use only gonadotropins, prefer an antagonist protocol, give agonist trigger when it's an antagonist protocol, and all embryos should be frozen for transfer in the future to prevent the OHS. I'd like to thank MC sir, experts and the panelists. If anybody would like to say something on ovulation induction, which they think is very, very pertinent, I would request the co-moderator, the expert and the panelists to say so.
There's one more indication for ovarian drilling in my part of the where I practice, because many of them are abroad, so they are when they come back, they want to conceive fast and there's no time. So we do the drilling and start the stimulation fast.
Oh, okay. Anita?
Ovarian drilling, not much patients are nowadays coming. So with the drugs, they are doing wonderful work.
So what is a protocol which is working for you?
For me, you use letrozole with HMG.
HMG. Oh, okay.
Yeah. Most FSH, I'm not much used because both have the same results. I have the choice of using HMG.
But now I think you should shift on to an extended protocol of letrozole.
Yeah, extended protocol already. Extended protocol are also used. A normal protocol for 5 days also we have used.
Okay.
But
how do you feel that the extended protocol is working?
I don't see much for multifollicular development with extended. Even with extended regimen, if they're patient, they don't have follicles previously with their doses. They have only 2 to 3 follicle development like that only. Not much multiple follicles, even if we extend the regime.
Okay. So you are having good results with the extended protocol, right?
Yeah. No, I won't say much good.
Okay.
Okay. It's better. It's better.
You feel HMG is better as an add-on compared to increasing the dose?
Yeah, sometimes. So most of the times, but I'll say sometimes, most of the times it also works good. But no, I don't give HMG in the initial phase itself. At least for 2 to 3 months, I try with letrozole alone, and we'll see if the ovulation is not there, the follicle is not responding, then I'll go in for HMG. Not in the first dose or in the first month or in the second month itself, I'll give HMG.
Okay. What about the addition of metformin? Does it help?
Yeah, PCOS, it will be helpful.
Okay. What is the dose of metformin which seems to work?
I used to give 500 milligram BD.
BD, okay.
Yeah.
Only when you document insulin resistance you would do, or you would give for all your PMOS patients?
Most of the PMOS patients we used to give.
Have you ever seen any vitamin B12 deficiency when you're giving metformin?
Usually give it along with B12.
They have gastric discomfort, giddiness, Most
No,
of the
you
complaints are
you
used
should
with
look into the vitamin B12 deficiency in
B12 deficiency.
long-term use of metformin. You have seen
Yeah.
quite a number of patients. So that
Okay.
history also. So
Better
how
to give with metformin, B12 also.
B12, it's
B12
better
also.
that we give because the vitamin deficiency happens in a big number of patients, which you're
Most
not
of the
aware of at all. Yeah.
for the ovulation injection for this patient, you give folic acid. So with the combination of folic acid, most of the time B12 is also there.
Yeah,
So
yeah,
most of the time it's
yeah.
working.
Yeah.
So we
Some
don't see
add-on is
much
there.
B12.
Yeah.
Yeah.
Okay.
Folic acid you used to give now
Okay.
with the combination.
What about myoinositol?
Myoinositol also we are using for obese patients. Obese
What
patient
about
as
the
an add-on
combination
therapy.
of metformin with myoinositol? How many are using that?
Yeah.
Ma'am,
I use for adolescent PCOS, PMS. It's working. It's working.
So how long
Not for,
are you giving myoinositol?
I'm giving at least for 6 months.
6 months you give.
With metformin, at least
Anita,
for 6
present your
months.
data, no? Present your data.
Okay.
Do a study.
Okay,
Present
ma'am.
your data. And
Yeah.
any of the other panelists are using myoinositol or combinations of metformin with myoinositol.
Previously, we used like
combination.
lot for every patient. We wrote myoinositol. Nowadays, I have stopped using because I couldn't see any difference at
Better
all.
results.
So the only thing I trust is folic acid along with B12. If at all I would add steroid Dexa 0.5 mg
How
for
many
ovulation
days?
induction
How many
for
days?
10 to 15 days.
When will you start the Dexa?
From day 2. Day
Day
2
two.
to day 10.
So only with hirsutism features you start steroids, or non-hirsut also you start steroids?
For hyperandrogenic features, obese
You
PCO.
start on steroids. Okay. So you
Steroids.
think
So-
there's a non-classical type of adrenal origin and then you give
Yes.
that. Okay.
Yes, I would start with steroid, folic acid, metformin, like 500 mg BD, or I would go for 850 BD. That really helps in getting an ovulation.
Ovulation.
And if I could see if it is a like resistant PCO, 25 to 30 follicles are there, because I have seen one girl who was treated with somewhere else, but I truly thought I need to achieve somehow the dominant follicle, because exactly she said like, madam, நான் எங்க பார்த்தாலும் பார்த்துட்டேன், இது வரைக்கும் எனக்கு follicle வளர்ந்தது இல்ல. So that's what she said. So நான் நினைச்சேன் ஏதாச்சும் நம்ம பண்ணலாமா, பண்ணி இதுக்கு ஏதாச்சும் ஒரு pregnant ஆதோ இல்லையோ ஒரு follicle நாச்சும் கொண்டு வரணும். Then I tried 5 mg for 5 days, then 7.5 for 5 days, then 10 mg. I asked her to come by day 14 or 16. That day I got 19 mm follicle.
Okay.
Then HCG, single dominant follicle 19 mm. I gave trigger HCG 10,000. She couldn't get conceived, but எனக்கு அது ஒரு நல்ல ப்ரோட்டோகாலா இருந்துச்சு. ஓகே, ஸோ இவ்வளோ சிவியர் பிசிஓ வந்தாலும் 5 7.5 போட்டு நம்ம ஏதாச்சும் ட்ரை பண்ணலாம் அப்படின்ட்டு then I thought.
Did you give steroid for that patient?
Yes, ma'am. Steroid, metformin
you are given.
Metformin 5, 7.5 and 10. Because
Pirov was talking on Dexa being given for most of the androgenic PCOS, but in the recent Pirov it said no. You need not give steroid because they said it is not an adrenal origin which you need here. So that even if it blocks, it's not going to help much, because the ovarian androgen is the one which is going to cause the milieu is going to be changing there. So now the recent Pirov is not talking about steroid.
Only from the adrenal source we need to give.
So it may not work for PCOS. They think it could have worked in your patient, but it's not like you cannot give it as a recommendation that you give steroid for all your patients who are not responding to letrozole. Vidya wanted to say something.
Yes, ma'am. That same thing. Earlier, we used to use Dexa for stimulation, especially only in resistant PCOS cases with excessive hyperandrogenism. But nowadays, after the recent evidence, I have stopped using. As far as metformin is concerned, yes, in women, obese PCOS women who are showing signs of insulin resistance like acanthosis and all that, but I don't really do any laboratory investigations to confirm insulin resistance before initiating metformin. As far as
do a glucose tolerance test, right? You should do an oral glucose. That you should do always.
Yes, that we always do for screening. Myoinositol, I've been using as a combination with metformin. As you also shared your experience, even I have not been able to see any significant difference in terms of results.
I was in Kolkata like 2 days back, and that combination we were talking on, one doctor was talking on that her patient developed hypoglycemia. She said with that combination, myoinositol, metformin, she was complaining of hypoglycemia. So it's not like everybody is immune to hypoglycemia when you give metformin. So be very careful. And she said, I said you at least taper the dose and give it a smaller dose. She said, no, I've stopped it at all because there was no response per se, other things, only the problem was there. So remember, the combination can lead on to hypoglycemia also. So
I'm actually using this. Previously, we used to use it for patients who are intolerant to metformin. But now that the combination of myo-inositol with metformin is only in the market, plain inositol is no longer in the market because all the companies are coming with a combination. So, for my patients who are between 18 to 20 years, pre-marital or obese, almost on the PCOS side, I use it for 6 months. Once I give metformin in the morning and the other metformin is with myo-inositol. So I find these patients reduction in weight is better, and also the patients conceive earlier when they get married.
Okay.
Yeah.
Dr. Pushpalata, any special regimes you have? Dr. Pushpalata, we are not going to leave you. You have to ask, tell us. Dr. Pushpalata. Okay, Renju.
Ma'am?
So what, any special regime you have for ovulation induction? We are trying to figure out for our patients, actually. I'm getting the secrets.
No, ma'am.
I want to share one funny anecdote that happened in my hospital. Actually, the patient was, going for IVF. So the letrozole had to be started on day 2 to day 6, and then she was to be given gonadotropin. And the letrozole was not given in the pharmacy. The patient went in for straight gonadotropin. And then, I was, very angry with that, with my people. Why are you so ignorant and all that? Then I said, we discussed with our team, and then they said, okay, no problem. You can give letrozole even on day 9. So day 9, 10, 11, 12, 13, she received that 5 milligram of letrozole, what had to be given from day 2 to day 6. And then this patient conceived beautifully. And she had live pregnancy and all that. So this is an area of research, like what you say. I think we need a lot of data and everything. We should compile everything. And we need to start letrozole. Even later starting letrozole is okay. But
it might work. I've had patients who have the second dose of letrozole, and then when the follicle comes, many conceive. So it's not like you miss that early days and then you have a later follicle. Even if it's a later growing follicle, pregnancies still happen quite a lot. So we'll ask Sadapti, who's an IVF specialist from West Bengal. Sadapti. She's an IVF specialist. Sadapti. All have disappeared. Okay.
Yeah.
Have
you given single dose regimen letrozole?
I've given. It's given me results. So suppose patient comes late, Anita, that day 5 she has not come, she has come on day 6, and still the husband is going off in 1 or 2 months, and she keeps on saying, we have given 25 milligram on single dose.
Okay.
6, so that means 15 milligram. 15 milligram. 15 we give. We don't give 25.
There are no side effects, huh? There are no
nothing happens. Nothing happens. So we give 15 milligram, and then you call her after 5 days. Day 6, and after 5 days, beautiful follicle will come. It will come.
Good.
Yeah, it's a good regime.
Thank you so much for this information. You used to think after 5 days, if it's not working, then only in the next cycle we'll increase the dose. But this time we have learned new things from you. Yeah, thank you.
Suppose you are given a longer dose of letrozole and still she's not formed a follicle and the endometrium is thin. That means still her recruitment has not started. So what you do, you can start then also. Nothing will happen.
Okay.
The one benefit in PCO is there is no fixed proliferative phase. So you can increase the cycle. Even few may develop on day 21 or day 22. That is a benefit for
and
us.
as Vijay Prabha said, sometimes when you just leave them alone without any increasing dose also, later they'll have a follicle. We have had pregnancies like that. We have they'll come with delayed periods. We'll say no egg came last time. So something like that. At least check a pregnancy test. Many times she'll be pregnant by herself. one late follicle would have come and should have conceived also. Because happened many times. And we start giving that medroxyprogesterone, thinking, okay, we'll have a withdrawal bit. She will not withdrawal bit, then she'll have a pregnancy. So be very careful with PCOS patients.
Yeah.
Do pregnancy test as much as possible. You will get some results somewhere. Yeah. Yeah. Thank you so much. It's wonderful talking to all of you. Thank you, Dr. Anita.
Thank you, ma'am. Thank you for this opportunity.
Yeah, thank you,
Thank you,
Dr.
thank you, ma'am.
So
Yeah,
much.
Thank you, ma'am.
Pushpalata as
Actually,
well as
enjoyed this session.
Angie. Yeah, thank you.
Yeah.
Thank you. Thank you, MC sir.
Thank you,
Thank you
ma'am.
so much.
Yeah.
All the
So
best, sir.
big,
Best
big,
wishes.
big round of applause from both the moderator and experts and all the panelists.
Thank you, sir.
Putting their expert inputs, making this panel very interesting and fruitful.
Sir,
Yeah, yeah.
thank you so much.
Thank you for accepting our invitation to
Yes.
join this webinar and in this panel.
Sir,
Thank you.
wishing
Thank
you
you, sir.
all the
Thank you
very
very much.
best. Wishing you all the very best on behalf of Trichy Society for the
Thank you,
forthcoming
madam. Thank
elections.
you.
All the very
Thank
best,
you.
sir.
Thank you.
Mhm.
But
Sir, best wishes.
you all have to vote and make others also to vote.
Sure, sir.
Yes.
Thank
Yes.
you.
Best wishes, sir. Best wishes.
Thank you.
Thank you, Charmila ma'am. Thank you, Anita ma'am.
Hey,
Thank
we
you
were
for the
asking you a
panel.
question. You disappeared. So for your
Oh, is it,
IVF
ma'am?
center, you tell the answer before you go. Ovulation induction PCOS, what is your unique protocol? We want some secrets.
Ma'am, I have started using from the past 6-7 months. I give the PCO ones, which with the moderate body weight. I give twice daily letrozole from day 2 to day 6.
Okay.
Thrice daily letrozole from day 7 to day 11, and I do a scan on day 12. It is giving me very good results, ma'am.
Oh.
No multiple follicle, single follicle, nice.
Oh, this is for resistant or for all your patients?
This is mostly for the resistant ones.
Resistant cases.
But 5 days letrozole I have stopped giving, ma'am.
But where is this
Twice daily, so I
protocol
give only
from?
for 20 days.
Which study is
I
showing
don't
this?
know, ma'am, from my mind, but it is giving me good results, ma'am. Really, man, I don't have any evidence to quote, but I'm getting very good results, ma'am. Patients are conceiving, even the IUI ones, no. With this twice daily for 5 days, followed by thrice daily for 5 days, I
But
am
there
getting
are
very good
studies which
results.
say that you have to give letrozole only in the night, which gives a better result. You giving it twice a day is not an accepted protocol.
Yeah.
You have to give it, if you give 7.5, also give all three together
Single
in the
dose.
night.
Together.
Okay. But I am getting good follicles, ma'am. My need of HMT has reduced by a
I know
lot.
that.
Man, I am
No,
barely using
You
HMT
give
in these
all
cycles.
together, it will work the same.
Okay, I will do that, ma'am. I will do that. I will do that.
Okay.
Charmila,
Yes, sir.
it is going to be Satabdi's protocol.
Satabdi's protocol.
Maybe.
I should try to gather the cases and try to do something about it, sir. Even I have been thinking so. But I don't know whether scientifically it is correct or not. Just because I'm getting results, I'm using it, ma'am, for most of my
You present your
PCO-resistant
data.
ones.
So somebody will take it as there for their research, they will take as a study for this thing. Pilot.
I should do that. I should do that.
Thank you so
Thank you,
much.
ma'am.
Thank you.
Thank you,
Thank you, ma'am.
everyone.
Thank you for the wonderful opportunity.
All of you to please vote and support for MC sir. Request and motivate the people from your society to vote and support MC sir. He has to win this time.
Thank you so much.
Definitely, ma'am.
Thank you, sir.
Thank you.
Good night. Good night. Good night,
Good
everybody.
night. Good
Thank you,
night.
sir.
Good night.
Thank you, ma'am.
sir. Thank you, ma'am.
Thank you.
Yes, Corona people, we can conclude. Thanks to Corona for educational and this technical support. Corona is with us since long in this series of Happy Learning Masterclass.
Thank you so much, sir, MC sir, and all the requested faculties over here, right? So on the behalf of Team Corona Remedies, once again, I thank you all for sparing your precious time, and let's conclude the session right now. Perfect.
Oh, yes.
Okay, sir.